concluding session of Health Tech. Tech for Saving Lives is the theme this year, and it is a part of day 2 of Health for Inclusive Growth. The Bengal Chamber is presenting with CENERS-K and Medica Superspecialty Hospital. So in this session, we are addressing technology advancements in healthcare, which will be discussed by expert doctors. And this session is being chaired by Dr. Robin Chakraborty, Senior Vice Chairman, Cardiology Services and Senior Consultant, Interventional Cardiologist, Medica Superspecialty Hospital. We have with us Dr. Sanjay Mehrotra, Senior Consultant, Interventional Cardiologist, Narayana Rudhalia, Bangalore. And followed by that, we'll have other speakers, Dr. Ashish Pathak, former Professor, Neurosurgery, and Dr. Srinivas Chilukuri, expert in Proton therapy in radiation oncology, and then Professor Amit Dinda, ICMR Emeritus Scientist, Department of Pathology, Chief Coordinator, Center for Medical Innovation and Entrepreneurship, EMS, and Dr. Shiva Prasad Roy Choudhury, Professor, University of California, Davis. We would begin with our first speaker, that is Dr. Sanjay Mehrotra, Senior Consultant, Interventional Cardiologist, Narayan Rudhalia, Bangalore. I would request Dr. Robin Chakraborty to please take forward the session. Sir, you may please call the speakers one after another as you deem appropriate. Thank you.
Thank you very much for having this session. So we are going to start the session on, as we all know, that aortic valve replacement is being conventionally done by the surgeons by replacing the valve with a mechanical valve or by a prosthetic valve, but by a surgical incision. But over a period of years, and I would say for the last 2 decades, there is a significant change in the technology of valve surgery. And now people are actually trying to replace the valve through catheter called transcatheter aortic valve replacement. And progressively, I would say for the last few years, it is an acceptable option to consider transcatheter aortic valve replacement, conventionally called Tavr, sometimes called transcatheter aortic valve implantation or TAVI. And in India also, we are increasing, there are increasing use of this aortic valve replacement by a catheter. In fact, in our hospital, we are doing on regular basis. And right now in Eastern India, we have the highest number of transcatheter aortic valve replacement or aortic valve implantation in India. Sanjay Mehrotra is a very accomplished interventional cardiologist whom I know for many years, and is a very good friend of mine. And probably he is one of those very few beginners of transcatheter aortic valve replacement in our country. And Sanjay, by this time, has profound experience. He has actually gone through this journey of Tavr over the years. And I'm sure he can be the best person to address this session of how technology has changed the valve surgery, particularly the aortic valve surgery. With this, may I request my friend and senior consultant interventional cardiologist of Narayana Rudhalia Hospital, Bangalore, Dr. Sanjay Mehrotra, to talk to us on percutaneous valve treatment of aortic stenosis. Sanjay, all yours.
Are you able to hear me, Robin? Robin, you are muted. Can you just confirm if you can?
Yeah, I confirm. You are loudly audible, like right. Me. And please go ahead.
Thank you, Robin. Of course, thank you very much for introducing me and bringing me on this platform, which I presume is a combination of doctors as well as non-doctors. Is that correct?
Correct.
So I'm going to talk very basic about what is aortic valve disease, what is its prevalence, what is its status in India, and where it's going to go. Of course, we have had a long journey of initiating this percutaneous treatment of the aortic valve disease. I started in 2012, so it was almost nearing 10 years of doing this. And before I go into the many details about how this procedure is done, I would like to tell you what exactly you mean by aortic stenosis. So aortic stenosis is the narrowing of one of the valves of the heart, which is between the main pumping chamber of the heart called left ventricle. Your heart is situated in your chest here, and it has 4 chambers. The main chambers, which is the pumping chamber, is called as the left ventricle, which receives purified blood from the lungs where oxygen is being added. And this blood has to be pumped into the body through this huge tube system, which is called the aorta, from which branches are going to every part of the body, every cell of the body, the blood has to reach. Now, in between the heart and this big tube called aorta is this valve called aortic valve. And this valve, when it gets narrowed, we call that condition as aortic stenosis. So the aortic stenosis, which is, of course, very common as an age-related calcific aortic stenosis. So what happens is, as we advance in age, this valve becomes thicker and thicker, going through the burden of being hit by the force of the blood. It becomes narrowed and sclerosed and atherosclerosed, and that is the most common cause. In our country, although all patients which we see after 50 years of age have another important cause, which is because of a congenital abnormality, where instead of 3 cusps of the valve, you have only 2 cusps. This is called as the bicuspid aortic valve. So normally there are 3 cusps. In certain people, you're born with 2 cusps, and this is the second most common, but not far behind is the rheumatic valve heart disease, which also involves aortic valve, and that is causing the aortic stenosis. And that also happens rather early in our age, although in the heart, in rheumatic heart disease, mitral valve, which is the other valve on the left side, is a more commonly involved valve. Now, what are the symptoms of aortic stenosis? So what happens over a period of time, such a person will start becoming short of breath. He may complain of chest discomfort. He may complain of easy fatigability. And sometimes they start becoming giddy, and so much so that they can feel like they're going to fall, and sometimes they faint. And many times people misunderstand these symptoms, thinking that they are becoming old, and that is why these symptoms are happening. And very soon, when we correct this problem, they come to know how much better they have become and how much restricted they were. Also, along with that, there may be other symptoms like irregular heartbeat and sometimes palpitation. So these are the common symptoms of aortic valve disease. Now, a healthy aortic valve, which you see on the left side, is prevalent in about 4 to 5% people of population after 75 years of age, and the aortic stenosis. And when this valve becomes less than 1 square centimeter, we call it severe aortic stenosis. And all these people who have these symptoms, and if their valve has narrowed to less than 1 square centimeter, they require treatment. You cannot leave them. Otherwise, their lifespan is limited. After severe aortic stenosis becomes symptomatic, most of them, 80% or 90% of them, will not survive 5 years. And this is a very bad prognosis of aortic valve disease. So 5-year survival of breast cancer, lung cancer, prostate cancer, ovarian cancer is much, much better. But if you have inoperable aortic stenosis, your 5-year survival is 3%. And look at this. So this is worse than other diseases which you come across. Of course, lung cancer is not far behind, but all the other cancers will make you live, but this disease will not make you live, and you have to correct it. And also, a lot of people are not offered surgery because they become old. And this was a limitation which you used to feel 20 years ago. But we are thankful to the technology development of one individual. His name is Professor Alain Cribier, who is here, and we have an opportunity to work with him, who had this idea that he will create a valve which can be implanted into the heart, And his thought came in almost like 1994, but the first valve implantation was done in 2002. And we also had an opportunity to work with him. We have been to his center, that was in 2002, where and of course I'm much younger at that time, where he was, but this is, we are doing something else. Obviously, this was not the transcatheter, but he was the first transcatheter aortic valve implanter. Let me just go back to this slide. So what happens, who needs this treatment? All those people who have severe narrowing of this valve need treatment. They're on, for the doctors, if their velocity across the aortic valve is more than 4 meters per second, or the mean gradient is more than 40 millimeters, they require treatment. Or if their valve area is less than 1 square centimeter, or the indexed area is less than 0.5, they require treatment. Sometimes when the heart fails, you actually will not find these gradients, but they are sick people because of the valve, the heart has failed, and all of them will require treatment. Now, the field of percutaneous valve replacement and repair has developed at a very rapid pace. And this is the treatment of choice for this disease. And this is the fastest developing area of cardiology. And we will not be surprised if we become in India the largest operators in the world, because we have such a huge country. And I'm not very surprised if China has already surpassed any other country. Well, we don't know about China because China is a very, he doesn't tell you what he's doing, and we don't know about it, although we know how much they do. Now, TAVR is available now more than 65 countries across the world, including us. And of course, the largest implanters at this time are the Europeans and the Americans. Well, as I said, I don't know about the Chinese numbers, but they're not far behind. They may be actually more. We are now reaching a point where we are likely to become the largest in the world. And we are witnessing a revolution in technology. You see on the left side, a person's chest is opened up and you deploy a valve, although this is also becoming easier. On the right-hand side, we can do it in a cath lab, and I do it completely under no anesthesia, under local. And I did one doctor from Kolkata, who was a good friend of mine, just about a couple of days ago. He came in heart failure. He was not able to walk, PND, and we did yesterday. Today he says, I have become a new man. And this was done yesterday. I will discharge him tomorrow. So this technology is so rewarding, especially for a patient. Of course, doctors feel happy when their patients go home, but this technology is extremely rewarding for the patient. They become really, really well. Now we use two kinds of technology. One is called as a balloon expendable valve, which is made mostly by a company called Edward. And we also have an Indian company who has made valve, which is pretty good, similar. This is a valve which is a self-expanding valve. Various companies make it. The common one in India, which are available, is a company called Medtronic. The other one is a company called Abbott Vascular. Both of them have technology, and some other Indian technologies like the Hydra valve is also available in our country. Now, when we do this planning with the patient, we do the clinical risk assessment of this patient. We usually don't offer this to younger people because they still are better with surgery. We do their echocardiography, we do their angiography, but the most important test which we do is contrast CT assessment to tell us about what size of valve, where do we put the valve, how is the path where we go, and I'll show you how we do it. So I'm going to show you one case who's a 79-year-old gentleman in cardiac failure. That means his heart has failed. He has got severe congestive heart failure. His body is swollen. He can't lie down. He's breathless. We tried to stabilize him with drugs, and we thought that he's become better. Now, before we planned the procedure, we have to do a CT. So we took him to the CT room and he arrested there. He died while he was undergoing CT, and we resuscitated him, brought him back to the cath lab, opened his aortic valve. And this valve, which you see, now we are just doing a balloon valvuloplasty. We're not implanting the valve. In a situation like this, when the person is dying, sometimes just opening the balloon with the balloon is enough, and then you plan the Tavr maybe on the same day if it is available. Because we did not have a CT on this patient, we could not do the Tavr. We just do a balloon valvuloplasty to save his life, and then we performed a procedure, and this is how the procedure is done. So we are inserting the valve, which you see is inserted from your leg. It goes up in your chest through a wire which has been already placed in your heart. I'm going to move faster. So, no, sorry, that probably was a wrong video. So we are crossing the valve, which is narrowed, which has been opened 3 days before. This is the correct video. And once we cross, you will see the wire going inside the heart from the aorta through the aortic valve. And then we, I'll just move a bit forward quickly. And then we bring a bull. Here we've already dilated this. So we directly bring the valve in this patient after we have established the necessary equipment which is required. So the valve is loaded on this tube system, which is outside the body. And once the valve is loaded, the valve actually comes separately. It is loaded on this tube system, which you see here. And once it is loaded, then we insert it into the body. So I'll go to the next. So once you advance the valve and it has reached, we allow this valve to expand by unsheathing the valve. And there are certain pointers by which we come to know where to open the valve. You see, we are turning the handle outside here, and the valve is opening in the chest. And you see the valve is opened up. And this is a metal frame, and the valve is actually sewed surgically by hand inside there. And this valve is a bioprosthetic valve. So this is a self-expanding balloon, a valve which we have deployed. I'll go to the next one. Is another lady where we have put in a balloon expendable valve. She's very young, but has got very, very bad lungs. And the surgeons say that we will not do it. And also she was not willing. And this is a bicuspidiotic valve, which is this valve, which I showed you. This is the valve. This was a self-expanding valve. This is the other valve. So again, we are trying to cross, and you see the wire goes inside. And then we pre-dilate this narrowed valve, because unless you dilate, the whole larger device which we have to put in will not go inside. So we call it balloon pre-dilatation. Then we take this valve, which is again loaded on a balloon. We position by certain markers, which we understand by our experience, where to deploy. And you will see the deployment in the next frame here. While deploying this valve, we have to pace the heart very fast. Otherwise, the valve will not stay. It will move up. So if you keep watching, it's just a bit slow, but you'll see now the valve will start opening. So this is the valve opening now in the second frame. And this is one-time deployment. You don't have a chance to reposition your valve. The first technology which I showed has a possibility that you can reposition the valve if you don't like it. Both have their advantages and disadvantages, but both work very well. So I choose my cases depending upon what a particular patient is more suitable for. Now, coming to why we are doing this, because the risk of a surgical valve replacement as we become older becomes more and more. And until this was available, almost 30 to 40% people would not given any treatment, and they died in a matter of 2 to 3 years. And even in our country, at this moment, a very large number of patients are untreated. There is a suspicion that you would have 5% of 75% years of age would have this disease. You see, huge number of patients who need this treatment. There are certain cost implications of this technique, but I'm pretty sure that if the cost comes down, we will have many, many people who will be requiring this. And when you compare this valve who are more than 70 years of age with surgery, this valve is much, much less risky to do, with a better quality of life, with no operation, second, third day discharge, while somebody at 75 who undergoes a surgical treatment has to go through a lot of pain and trauma before he can be mobilized. The durability of the valve, when we compare to it, a surgical valve, which is bioprosthetic, is also becoming better and better. Now, what are the main challenges in India? So obviously, this procedure requires a longer learning and developing process because we require a teamwork where surgeons are also very important. So we have to work with surgeons to learn this technique and grow in our technique and start doing large numbers. On an average, I'm doing something like 2 or 3 Tavrs each week these days. I have so many patients waiting. Next week, I have to perform at least 3 Tavrs. So we have a large population, and I'm pretty sure very soon the whole country will start doing in large number. Affordability is a problem. It will remain a definite challenge, but I hope that Indian technology or new technology which become available to us will be cheaper and more available to people. We do feel that you will require to do larger volumes where a center is capable of doing it is also something which will remain limited to few places, but this would be probably available to many, many centers in the country because a lot of our centers have become now capable of doing it. Of course, as I said, cost is an important aspect, and we need to talk to the patient's family because many times losing such a patient, because there are risks in doing this, although they are less than 3 to 4% now, but cost being such an important concern to our patient, when we lose a patient because of a complication, which is, I am telling you, will become very, very, less. Thankfully, in the last 2 years, I have not lost a patient, which is very good, very, very good number. Now, what is the future of Tavr in India? In US, there are about 1,400 cath labs and 400 centers doing Tavr. India has already got much more cath labs, and approximately 200 centers will be performing Tavr by the year 2025. By the year 2025, numbers in India will overtake the surgical valves which are being done. And I'm pretty sure that we will be doing approximately 4,000 cases per year in no time. Just wait, and more centers will start doing it. And I am pretty sure that the skills of Indians are actually pretty good. So we would be doing very large numbers. And I think that's my last slide. Thank you very much for your attention. I hope I have covered what is important for an audience to listen in about 15 to 20 minutes time. Robin, please, your comments.
Thank you, Sanjay. That was really wonderful. Very nicely you covered up in such a short time. And clearly your talk did show the application of technology in today's healthcare, particularly in cardiology and cardiovascular intervention. And valve surgery and valve intervention is a upcoming cardiovascular intervention, and we, the interventional cardiologists, are gradually getting into it. I don't know whether surgeons how they do feel about it, but I'm sure without their help, this technology could not have been evolved, could not have developed for us, for the cardiovascular interventional cardiologist. The quick question is that you have shown very nicely that futuristically, or maybe in next 3-4 years time, the number of procedures in India by Tavr will increase, and huge number of patients population also will get benefit out of this technology. We do see cases almost every day, some kind of aortic stenosis at some stage, and we started talking to them. But as we all know, that cost is a prohibitive issue which has to be addressed. And as you said, that the Indian companies are coming up with a cheaper model. But what is your views about further reduction of the cost? Because that would be extremely imperative, as you know, that this is an important factor for Indian population. That is one. Secondly, as of now, as per my understanding, it is only being done for the degenerative aortic valve stenosis, not for the rheumatic aortic valve stenosis. So, and we know that when in India, we've got a huge number of rheumatic aortic valve disease, aortic stenosis, as well as mild aortic regurgitation. And finally, the third question is that we mainly do it on aortic stenosis, but there are situations when you've got a mixed aortic valve disease, like aortic valve leakage, along with aortic valve obstruction. What are the, so will those patients be benefited by transcatheter aortic valve replacement? The three questions. Thank you, Sanjay.
So I thought you asked the first question about the cost. I do feel that even the foreign companies have reduced their cost when it came to the introduction of technology, say around 10 years ago. And I'm pretty hopeful that the cost will come down. It is still not covered by a lot of insurance companies, that amount, but insurance companies are also likely to include this technology in coverage. Now, as far as Indian valves are concerned, I feel that a 5 to 10 lakh cost is a reasonable cost. There is a possibility that some company will bring it sub 10. I don't want to take names, and even the competition will bring the cost further down. We have all felt that, of course, I also say to my patients many times, how many cars do you see on roads which are more than 5 lakhs, 10 lakhs? There are plenty. So affordability is an issue for a probably a commoner in terms of somebody who has a day-to-day livelihood, but most of the people are able to afford, and a very large number of people can afford. Now, there may be a very large number who cannot afford, but the number of people who can afford is also not small in our country. But as I said, that there would be a possibility that it will be under insurance, and that is why all these things are becoming important for us to consider insurance and have a larger coverage, and the technology would be available. That was your first question. And obviously, the new technology which device companies bring, they do a lot of research, they put a lot of money in it, and they obviously want to make money out of it. How can you avoid not making money to them? So
true, but at the same time, there is also some cost involved in the research and analysis.
Yes.
So that has to be recovered. There is no question.
That has to be recovered. So if they bring a new valve and the old valve is cheaper, I think we are okay with that. And new technology, of course, will be used by somebody. I think that was your first question. The second question was that mixed aortic valve disease and also rheumatic valve disease. So if he's a young man, because rheumatic heart disease is probably seen in younger people, we don't recommend to do it less than 65 years of age at this time, because the data is not there. It's possible that the evidence would be available in the next coming 10 years. Would it be better to put a Tavr valve and then do more procedure? Obviously, anybody who gets this disease at 50 years of age has a very high possibility that he may require 2 or 3 procedures in his lifetime. We want to make sure that he doesn't come back for 2 procedures which are invasive or more traumatic. So if suppose 1 surgery and 2 Tavrs is a good idea, or 1 surgery and 1 Tavr is a good idea. So first one would be a bioprosthetic valve, and then you can put a valve in valve over a period of time. The artificial valve companies have understood this requirement, and they've started making now surgical valves, which are later on can be treated by Tavr. And I think that is the improvement. So you force people to bring technology. The most important thing, which I feel, that our surgeons used to put very small valves in bicuspid valve. Now they are forced to enlarge the ring or not put a small valve. 19 valve is a no-no for anybody.
Gone. It's almost gone.
Horrible. So they have also improved in their understanding. I think cardiologists are forcing them not to put that.
Yeah, cardiology educated them to understand, because when you put a 19 valve, you are actually replacing aortic stenosis by another aortic stenosis.
Aortic stenosis, absolutely. The second thing, mixed aortic valve disease, if it is more than 65 and there is enough calcium to hold the valve, I'll put the valve. I require some anchoring material. If there is no anchoring material, then there is a new valve which has come called XenoValve, which is for isolated aortic stenosis, aortic regurgitation. But any aortic regurgitation, if there is calcification associated with it, then putting a Tavr valve is very easy. And I think, or a rheumatic heart disease who's more than 65 years of age, I would put a Tavr. There is no issue.
Agreed. That's the kind of point. What I would like to share, that even it is rheumatic aortic stenosis, I mean, the technology-wise, even the procedure-wise, there is not much of difference between replacing a rheumatic valve versus a degenerative valve. It is only the age. As of now, there is no such indication. But with time, with experience, with further advancement of technology of aortic valve itself, probably at some stage, non-degenerative aortic stenosis, other than rheumatic, there are many such conditions where there are aortic valve disease without any degenerative aortic valve involvement. The Tavr can be considered, but it's too early too premature to make such comment.
Correct.
Any more question from anyone in the panel? Although I have Amit, who is basically kind of now he's a nano specialist, a nanoparticle specialist from AIMS. Amit, you got any comment on this aortic, on the valve and your nanoparticle?
Yeah, so basically, as I think Dr. Mehrotra was pointing out, see, there is a lot of the development is coming up in the new generation of valve development with 3D printing and as well as the hybrid polymeric system, which are stimuli responsive polymer. And the reinforcing is sometimes done by the nanofabrication in the background. So that means the technologies are improving, and also the chance of reducing the cost is coming up because the new intelligent AI-based 3D bioprinting, which is coming up, so they can replicate these valve, produce this valve in large quantity with excellent quality questions. Right. So I feel these are all very, very emerging technology area, and it will evolve.
No, the future is pretty good, and I think when we start, making technology where it is suited for that individual.
Yes.
That becomes a more specific technology, and the usage and the lasting, how will it work, will be very efficiently developed. So this is the smart technology which will bring and which will come. And I think that's the second level or third level, what you call it.
Yes, exactly.
Although the previous levels is not that they will become obsolete.
No.
They may become obsolete. We all use this phone now, which is a smartphone, but
Yes.
other phones are not used. So we would have a combination of new technology, moderately old technology, or very old technology, of course, will not survive for a long time. The first Sapien XT was a difficult valve to put, and Edward Sapien 3 is very easy to put. So the valve technology, sizing, collapsibility of the valve, radial strength of the valve, smarter metals would be the future in terms of making the size of the device which is going inside smaller and more suited for the patient. And
at the same time, I think as we may understand that when you innovate or sort of try to evolve some kind of valve technology, you have to think of valve mechanics as well as the cardiovascular hemodynamics. So you have to combine them, merge them together to ensure that in human body there should be an ideal mechanics, because these mechanics are variable. They're not same in every human being. Every human size is different. Every human body is different. So mechanics is different, and hemodynamics are not exactly the similar. So you have to match these two together, and therefore so that it should work well. So anyway, thank you. Any more question for anybody? No. So Sanjay, great. This is great. Nice to see you. I'm sure that we'll meet again, but probably physically very soon. Nice for your presentation. Thank you very much from myself personally and on behalf of Bengal Chamber of Commerce to participate and deliver such a wonderful talk in this Health Tech Conference 2021.
You're welcome, and my pleasure, and all the best to you. Robin, I will go offline. Sure. I will be online, but I will not show my picture, and I will mute myself to see some patient. I still have.
Please carry on and come back to us whenever you get time. Meanwhile, the next speaker is Dr. Professor Ashish Pathak. He is actually right now busy in theatre. He will be back soon. Meanwhile, may I request Srinivas Chilukuri to deliver his talk on proton therapy in radiation oncology. Srinivas actually is working at Apollo Hospital, Chennai, and he is specialist in proton therapy in radiation oncology. And he has been recommended by his colleague as well as by the head of the Department of Radiation Oncology of Apollo Clinical Hospital, Apollo Hospital now, Dr. Arundhati Chakraborty. So with her recommendation, and with also from the recommendation from his own team, from his own colleague, I request Dr. Srinivas Chilukuri to talk to us on proton therapy, the newer concept of radiotherapy in cancer patients and radiation oncology. All yours, Dr. Srinivas.
Good evening, everyone. Thank you, Dr. Chakrabarti, for the invitation. Thank you, Bengal Chambers of Commerce and Industry. It is indeed a honor and a privilege to be speaking about something which is I can proudly say that I have been part of so far, and I would also, in fact, say that India is very fortunate. There are only a few countries in the world which has, adopted this technology so early, so soon, and to be part of that journey of India's journey of adopting proton beam therapy. I'm glad I'm part of it, and I hope you can see my slides and hear me clearly.
Go ahead.
So if you notice the cancer incidence map, this is from Globocan data, and you can see that the premature mortality resulting from cancer is approximately third or fourth in the countries like India, in certain Asian countries, the Middle East, and other some of the African countries. And it is indeed a major problem, and it is increasing. And you can see that India, since it is, it comes under medium human development index, we see that there is almost a 64% potential prediction of increase in the incidence of cancer in the next 20 years, in the 2 decades. And it is going to be everybody's problem. It's not going to be only problem related to elderly or a specific age group or a specific group of population. And deservedly so, there is a lot of emphasis on oncology now. And what I think, if I have to summarize the advance in oncology, especially from the technology perspective, in the last 2 decades or so, I can summarize by saying that it has moved from the era when we used to put patients into baskets and treat all of them in the basket very similarly. For example, if a stage 3 breast cancer patient comes, we would treat all of them alike with the same surgery, same radiation, same chemotherapy drugs, and very, very similar supportive care. But what we have realized clearly is that it is not sufficient to do that, and it's not right to do that. So there is a lot of emphasis on personalized oncology, wherein we are able to tailor the treatments based on many factors. The factors could be patient-related, tumor-related, as well as treatment-related. It could be tumor-related. We know now that there are specific genetic markers, biomarkers, which we can read and learn from the tumor specimen biopsy samples, or even imaging, wherein we can say that, okay, these tumors are more aggressive and these tumors are not so aggressive. So aggressive tumors would require a higher escalation or higher doses or escalation of treatments, and those who are not aggressive or indolent need de-escalation of treatment. And this is what we have learned in the last 20 years or so, to personalize the therapy. So not just in terms of treatment-related factors, but also tumor-related factors, wherein also the patient-reported factors, in the sense that if a patient has certain genetic predisposition for a side effect, or a different metabolic makeup for a particular, metabolizing a particular drug, we know that the dose required in that particular patient could be different from another patient who does not have that specific genetic predisposition. And therein we are able to see that patients need to be treated differently to have the best possible outcomes. And there are multiple ways. And you can see that I have listed multiple innovative technologies or multiple innovative steps which can potentially improve the outcomes of the patient. There are many such. There are also many which are in pipeline, which are already coming, already in the fringes, and they are ready to burst into the routine clinical practice, such as radiogenomics, radiomics-driven intervention, CAR T-cell therapy, flash therapies, personalized cancer vaccines, and gene editing, etc., etc. But today, I'm not going to speak about all of them, but in the next slide, I just want to summarize the 6 big advances which have already taken place in the field of oncology, and we have already started using in some form or the other. And those are oncogenomics, wherein we are able to better understand the genetic makeup of the tumor, and thereby interventions based on the genomics. We are also able to use artificial intelligence to diagnose patients better, to classify or categorize patients better. We are also able to treat patients in situations or locations where expertise is not always available with the help of artificial intelligence and big data. We are already doing that with the help of nomograms, algorithms, etc., and machine learning methods. Robotics, again, a major advance in the field of not just surgical field, but also in the field of oncology in general. Robotics is being used in almost all of the spaces in genomics. It has been used in surgical oncology in a big way, robotic surgeries we've all heard of, also in radiation oncology, in many other fields of medicine. Also, the immunotherapy, very, very innovative way to deal with cancers. With the help of certain chemicals, we are able to re-trigger body's own immunity against cancer, very unique way to deal with the cancer. And of course, I mentioned about the precision medicine based on all of these factors. And last but not the least, I would also like to mention about modern proton beam therapy. Well, this, before coming to proton beam therapy, let me at least tell the audience that what a percentage of patients, we've all heard that radiation therapy is used in cancers, and about 40% of curative treatments are delivered through cancer, either in the definitive setting or in the post-operative setting, or even sometimes in the pre-operative setting. And ideally, 55 to 60% of patients of cancer at some point would require radiation therapy as part of a curative treatment or palliative treatment. And we know, and we have seen many major advances in the field of radiation oncology, which essentially have what they have done is to limit the doses to normal structures and to focus on the tumors or the targets. We had different forms of treatment, gamma knife, in the last decade or so, brachytherapy, stereotactic radiotherapy, tomotherapy, Cyberknife, all these, I'm sure you must have heard about these, essentially all doing the same thing, focusing the dose to the tumor and restricting the doses to normal healthy structures. But traditional X-rays typically do deliver some doses to normal healthy structures. Whereas proton beam therapy, the reason why it is so unique and so special is that it delivers absolutely no dose beyond the tumors. And that is why we call as proton therapy doesn't have an exit dose. So there is no dose beyond the tumor. Almost all of the energy of proton beams is deposited within the tumor. And to understand that, you have to understand something of physics, some basic physics behind this particular phenomena. It is called a Bragg peak, wherein the protons enter a medium, could be body, could be, it could travel for a certain distance. We call that as range of proton beams. And then it would deposit its entire energy completely dead within the tumor and nothing beyond it. And because this has no exit dose, there is the lower doses which are deposited with X-rays become from low dose to no dose with proton therapy. Obviously, it is very pertinent to point that side effects result from the coincident radiation to normal healthy tissues. It is not possible to deliver tumoricidal doses to the tumor without coincidentally irradiating normal healthy structures, and side effects result from that particular phenomena. But if for some reason, if by some mechanism, if you are not giving any dose to the healthy structures, there would be no toxicity. And I'm sure it is very easily understandable for everyone. But because of this, there is a lot of potential impact. It could reduce the toxicity. It could reduce the incidence of radiation-induced second cancers. It could be very patient-friendly because the quality of life would be very good. It could also potentially improve the disease control rates. Not just proton. Proton has been there since last 30 years. But what has triggered this new era of proton beam, modern, that's why I mentioned modern proton beam therapy, is that there is something called pencil beam scanning proton beams. These are small Bragg peaks, which I've already mentioned, within the tumor, small Bragg peaks, which essentially irradiate the entire tumor without irradiating the healthy normal structures beyond it. And that is the beauty of this particular technology, wherein you could achieve what you have always dreamt of as a radiation oncologist, but you were never able to do it. You are able to do it with proton beam therapy. For example, if I'm treating a pelvic tumor, and you can see this pelvic tumor delineated in a green structure, and the high doses is being received by the tumor, and you can see the low and intermediate doses all across the body. So some amount of femur, bladder, rectum, all these structures are receiving moderate to intermediate doses of radiation. This is called helical tomotherapy, another advanced radiation therapy technology. And it essentially does the same, very similar to VMAT, which is also a very advanced therapy technique, and very little to choose between them. I mean, I would say tomotherapy is slightly better in terms of some amount of bladder sparing, but very little to choose. But if you see proton beam therapy, you can deliver the dose to the tumor. You could spare the majority of the circumference of the rectum without giving any dose to the rectum. So that is as pristine. It will remain as pristine as the patient is born with. Similarly, the bladder doesn't receive any dose. The bone marrow, the pelvic hip joint, and the femoral heads, which also are important structures for elderly patients, do not receive any dose. And this is the subtraction image, where you can see that with protons, you are able to spare all these healthy structures to all these particular doses when you choose to treat patients with proton instead of either VMAT or tomotherapy. Similarly, this is a child slightly older child who has something called medulloblastoma, another rare brain tumor. And you can see that we have treated with helical tomotherapy this patient, and then we also saw what proton could make a difference. You can see that essentially we are treating the entire brain and the spinal cord, but coincidentally we are radiating the heart, the lungs, the bowel, the kidney, the gonads. All of these structures receive some form of radiation. And obviously in a child, a growing child, all these structures are extremely important, including the gonads, wherein you will have to tell the parents that there could be fertility dysfunction, reproductive failure, etc., etc. But with protons, you can see that the dose is restricted to the brain and the spinal cord, and there is very limited dose anteriorly, which is over the vertebral body. So bone marrow is also spared. The heart, the lungs, the bowel, the gonads, the bladder and rectum, the thyroid, and the oral cavity, and rest of all these structures do not receive any dose, literally zero dose of radiation to all these anterior structures. And this is again a very satisfying thing to tell patients and their parents, that children and their parents, that they will be able to have relatively normal life as far as the organ function is concerned compared to conventional radiation therapy techniques. Similarly, this is a patient of prostate cancer, and you could again see that the doses to the rectum, doses to a lot of structures are spared. The sexual dysfunction is lesser with protons, lesser genitourinary and gastrointestinal toxicities. Very similar to the brain tumor patients, wherein you can see that most of the brain is not receiving any dose of radiation compared to a significant doses of moderately significant doses of radiation to the rest of the brain when you use conventional radiation therapy techniques. So essentially, depending on the site which is being treated, there could be multiple ways to potentially impact the outcomes of patients. It could be in pediatric, it could be in thoracic cancers, it could be prostate, it could be sarcomas, or head and neck cancers, or brain tumors, or GI cancers. There would be some benefit of this particular technology. Not only is the physical restriction of the dose possible with protons, there is also data to suggest that it can have a higher biological effect. So this is explained by dense DNA damage which happens with proton therapy compared to relatively sparse DNA damage which happens with X-rays, and this results in a higher biological effect. So those tumors which are relatively radio-resistant, sarcomas, chordomas, chondrosarcomas, or recurrent tumors which are resistant to radiation, conventional radiation and chemotherapy, could be potentially controlled with protons because of this phenomena. And that is why, now, of course, I'll tell you the problems with protons, but the fact that American Society of Radiation Oncology now recommends certain sites as potential standard alternative to conventional therapies, multiple disease sites, and it has also classified others where the evidence is emerging, wherein potentially proton therapy could become a standard in the future. And based on all that, almost, we have been fortunate to be treating almost all these sites which are mentioned on this slide with modern proton beam therapy. And essentially, because protons is rarely present in a country in a very few centers, obviously we have to prioritize patients who will really benefit out of it, or who would really benefit most out of it. And based on that, an estimate is has been made about 20 to 25%, about 1/4 of patients we routinely treat on radiation therapy would really benefit with proton therapy in a big way to actually get referred to these centers where proton therapy facilities are available. This is about 3-month-old data. We have treated about 400 patients so far. And we have treated almost all sites, whether it's pediatrics, neuro, gynecological malignancies, head and neck cancers, prostate and other genitourinary cancers, gastrointestinal cancers, breast cancers, thoracic, and bone and soft tissue sarcomas. And we have, because ours is the only facility in the entire country and the Middle East and Southeast Asia, we have been very responsible in terms of evidence generation. Every patient who gets treated, the data is kind of captured, and we are publishing these outcomes of the patients, both physician-reported outcomes as well as the patient-reported outcomes, because we all realize the importance of evidence generation for a new technology for a universal adoption. Just to give an example, we have published our pediatric outcomes in a very reputed journal, Preliminary Experience of Treating Children as well as Young Adults with Protons. And we have shown that the outcomes are very good. Early initial outcomes are excellent. And even the toxicity outcomes are very, very low compared to what we have been used to seeing with conventional radiation therapy techniques. This is the room which actually has treated now about 550 patients of proton cancer patients here at our center. And this is how the massive, huge machines are. And there's a 100-ton gantry. We have 3 such gantries. And you can see, I would look like a small, tiny person, even though I'm more than 6 feet tall. you can see that the machines are massive and they require massive upkeep and maintenance. This is the magnet, the beam transportation system. And the reason why I'm showing all these pictures is that the crucial aspect of healthcare that is three: quality, access, and the cost. Not just the technology. Technology is always important, but what is the quality of the treatments? What is the access, and what is the cost of the treatment? That also impacts a low and middle income country like India. And as I mentioned, we are extremely fortunate. Now you can see that there are almost, proton therapy facility in almost all continents. You can see that there are many countries, both developed countries, most of them are actually developed countries who have this facility. There are many under construction, many under planning, including places like Singapore and Australia are still under construction, and we are fortunate to be treating patients. Our patients have access to these modern therapy technologies, and the number of centers is increasing by the day. We also are very conscious of the fact that we need to be cost effective for our patients. And it has been shown, there is evidence already that protons are cost effective in certain tumor sites: pediatric brain tumors, select breast cancers, local regional advanced lung cancers, high risk head and neck cancers. But these are in the context of a developed economy. And we need to see really what proportion of our patients in India we can claim that proton beam therapy is cost effective. Of course, the cost is a moving target. The cost is likely to come down significantly as the technology improves, as the number of, as the access to the technology improves. But we all know that there are 5 phases of technology adoption life cycle. There could be a trigger. I think the pencil beam technology has been the trigger. Because of that, as I said, there are 5 group of people: either innovators, early adopters, early majority, late majority, and laggards. And as far as proton beam therapy is concerned, India has been an early adopter, and we have the visionary chairman of our hospital group who has, long back in 2013, almost 8 years back, has invested in such a technology, done a thorough research on it, brought down together a team of specialists from all over the world to run this particular facility. And we are fortunate to be early adopters at this particular stage. And I'm sure that as we see, there are many more countries which are jumping on this particular technology to be adopted and to make useful for the patients of their communities and countries. And hence, to conclude, proton therapy is innovative technology, is already a standard of care in pediatrics, in brain tumors, and certain head neck cancers, prostate cancers. And there is emerging evidence for several other sites. India already has one. One more is undergoing installation. This is at the Tata Memorial Facility in Mumbai, which is fortunately a government facility. Hopefully many more will emerge. There are many talks ongoing in private sector. There is, of course, a need for improving access to this technology for deserving patients who really deserve this particular kind of treatments. And hopefully with smaller footprints, it's likely that the cost is likely to come down, and the more treatments will become more cost effective, and the access will improve because of the reduced cost. So with this, I would like to thank the organizers for giving me this opportunity, and I would stop my presentation here.
Thank you, Srinivas. That was really a wonderful presentation, very pertinent in this type of session where we're actually focusing towards how technology advanced the healthcare, how technology is so important to contribute in a positive manner to human health and human life. So this is extremely pertinent. So obviously you can't run away without answering some question. So there are some questions. I can see Professor Ashish Pathak. He's an accomplished neurosurgeon whom I know for many years, and was professor of neurosurgery in PGI Chandigarh, and of course he was in England for a number of years. Professor Pathak, I think you would listen to Srinivas. He's a upcoming and very promising radiation oncology, particularly with area of interest in proton therapy. So what are your take on proton therapy in neurological or neurosurgical, surgically operable tumors, or for example, any malignancy in brain? Professor Pathak. You have to unmute. Professor Pathak, you have to unmute. Yeah. Meanwhile, Amit, you are online. So Dr. Amit Dinda is a prolific nano specialist, primarily pathologist, very close friend of mine from AIMS. And AIMS actually given him a space to evolve, to develop this nano technology in Indian scenario. So Amit's contribution is phenomenal in medical field and healthcare. Amit, what are your concepts or what are your thoughts about this proton therapy in radiation oncology?
As I think the earlier speaker pointed out, this is really a first moving, evolving technology. And if we see the total radiobiology associated interaction, then as he mentioned correctly, this technology was old, but actually the application was pretty new. Innovation has come for it. So in future also, I think there are work going on where this the setup which is currently needed for generating this magnetic proton beam, so they may be modified. And in fact, the maintenance, I think, I don't know exactly, but then I am involved in the infrastructure development in our NCI Jhajjar, National Cancer Institute Jhajjar. There we are realizing that maintenance is also a big issue in proton beam therapy. I think in that, so that component, I think you can comment on. I think I'm requesting.
Sure, I think Srinivas did mention about this. He said the proton therapy is a concept going on for many years, last 30 years, that's what he said. But it's a pencil beam, which is perhaps much more relevant, much more important. That is a kind of innovation which has been taken up with proton therapy. And that is why the precision of cancer cell care can be done. Srinivas, what are your thoughts on that?
So I agree with Professor Dinda, what he made a comment. It has been there for last 30 years. It's extremely promising technology. But it was, I mean, people were working in silos. It was restricted to some physics laboratories. Very rare patients occasionally used to, walk across the physics lab to get treatment done, and very few doctors were invested in it. And that is the reason why the technology did not take off as much as the linear accelerator technology, which was much more small, compact, cost effective, and very quickly we could change the things. But in protons, of course, it required a mammoth technology, huge maintenance. Even now we have a team of engineers who are working 24/7. Even on weekends, on a Sunday night, you will find an engineer within the campus to look after the machines. So as of now, they do require maintenance, high maintenance. But as Professor Dinda mentioned, now the cyclotron, which is the mothership where the proton therapy is generated, that is a huge equipment, which is the size of it is coming down significantly. We have now talk of laser accelerators, which are much more compact, and hopefully it could fit in a bunker such as a linear accelerator bunker. And in future, it would take over machines. But it would be, of course, a significant jump in terms of technology. It would take a lot of innovation to achieve that, to reach there. But the footprint, I mean, when I was doing my MD 20 years back, I was told proton therapy you have to install proton therapy. It would take area enough to, as big as a football field.
Yeah, correct, exactly.
Yes. And now it's not a football field. My hospital is fortunately a small portion of the football field. It's not as big as that. So the footprint has already come down. We are seeing the cost in front of us in the last 5-6 years. The cost has come down by 50%. So I'm sure many more innovations are still ongoing. And there is also a talk about flash therapy. I'm not sure whether some of you may know about it. That could that could even revolutionize the field of radiation oncology itself. So there are a lot of things emerging. So let's hope we will reach there.
Sure, that's great. I think Dr. Pathak has unmuted. So the question to Dr. Pathak was, as you are a prolific neurosurgeon with very accomplished career, what are your thoughts about the role of proton therapy in neurosurgically operable tumors?
I think proton beam therapy has been a landmark actually, so far as brain is concerned. Earlier we had gamma knife because gamma knife also has precision, and I'll be talking about it in my talk as well. But then gamma knife has got its limitation. It can only give radiation to definite size objects and lesions. So, but proton beam specifically in my field, I operate on quite a huge number of chordomas and skull-based lesions, which have got close proximity to nerves and brainstem and other important structures. And in pediatrics, as very well pointed out by Dr. Srinivas, I think it's a boon. The only issue that I'm facing even in the private sector is that the price is still not affordable for the middle class category people also, what to talk of the lower class people in terms of economic. So the issue is we have to somehow bring down the cost, or I don't know, when Tata Memorial comes up, I had always been talking to Dr. Jalali about it. When Tata Memorial for cost issues for the lower socioeconomic and the category people who can't afford. But definitely, given an opportunity, I would recommend proton beam therapy for specific lesions, as I mentioned, which would definitely have a much better effect as well as reduce all the side effects. And
but taking both your points further, just a quick question to Dr. Srinivas as well as the Professor Pathak. Do the insurance companies, they reimburse the proton therapy as of now? Has it been enlisted?
To the best of my knowledge, not sure whether they reimburse that.
Srinivas.
Yeah. So we have treated close to 600 patients now, and a lot of chordomas, as Professor Pathak mentioned. And fortunately, first 1 year we didn't have any insurances, but last 1.5 years or so, we are being able to convince the insurers that this is an alternative standard of care for certain tumors. Now we are routinely receiving coverage from insurance companies for pediatric tumors, for all the sarcomas, including chordomas and chondrosarcomas, both for skull-based as well as spinal ones. We're also receiving insurance coverages for lung cancers, prostate cancers, and specific head and neck cancers as well. So, of course, on a case-to-case basis, we will have to argue or justify why proton therapy would be really beneficial in a particular case with the insurance companies. But most private insurance companies are now aware of it, fortunately, and are readily accepting the fact that this is the way forward, and there will be some patients who will benefit out of it, and they are supporting it. So
thank you.
We are seeing insurance.
Thank you, Srinivas. That was a really wonderful presentation, very pertinent to this forum. Personally, on my personal behalf, I thank you, and on behalf of Bengal Chamber of Commerce, I also thank you and congratulate you for a wonderful presentation. Please don't go, stay, and Professor Pathak is already there. Amit, I think I'll call you after Professor Pathak because Dr. Raichaudhuri has joined us from California. Hi, Dr. Raichaudhuri, nice to see you. It is 4 o'clock in the morning, so it's a torture to him, but eventually he joined, which is very nice. He is very keen to listen to you as well as Professor Pathak. Professor Pathak, please go ahead with your talk, Neurosurgery in 2021, from primitivity to modernity. Professor Pathak, please.
Are my slides seen?
You're clearly seen. Your voice is clear. Just go ahead.
Right. Okay. Thank you very much. First of all, I thank the organizers and specifically Dr. Robin Chakravarti for giving this opportunity for give this talk. I would keep my talk very basic because I understand the audience is not so much advanced in medical knowledge, but obviously technology can always be described to the people so that I can make them aware. And I'll quickly go through all the advances that I have seen in my own life. And when I'm talking life, I'm talking medical life, and which started. Now, it's not the infantry which actually fights. You have the Army Medical Corps, the Engineering Corps, and every supportive facility which actually helps the Army to win a battle. Similarly, in neurosurgery, the neurosurgeon has only limited role if he is not supported by various other technologies. And I have enlisted them, all these things which have really changed the scenario from what it used to be earlier. Let me start with a small story of my life. And I'm fortunate to have Dr. Ravin Chakraborty with me as the chairperson. And I have to make him recollect his days when we had the association of he being the intern in my unit and I was the SHO. And any head injury which used to land up in those days, the only thing we did was a plain X-ray, put the patient on a catheter, run a 500 ml of mannitol intravenously, and then explain to the family, this is all the thing that we can do now, and rest is in God's hand, whether the patient is going to survive or not. So that was, I would say, the prehistoric time when head injury used to be treated. Then came CT scan, and we thought, well, now we have got something to know what is happening in the brain. And we thought that's probably a huge leap. But mind you, beyond the CT scan, things have gone so far that the diagnosis has really changed. Apart from the diagnosis, the technical advances, the technological advances, the therapeutic advances, and more so now, the rehabilitative improvement has played a great role. And as I described, radiology has probably revolutionized what we never saw earlier with our own eyes before we really did a surgery can now be practically seen on radiology. And you can have a virtual view of things inside before you really have to operate or make any plans for surgery. So radiology is not only just CT scan, MRI, or CT angiography, MR angiography. It has got intraoperative localizations. And then you also have therapeutic and diagnostic approaches to radiology. And I'll gradually show some examples of how things have really changed. This is a digital subtraction angiogram, and these are the major vessels, and they subdivide into smaller vessels and the finer branches. So this is the zoom picture where this patient who came with a bleed in the brain, you say everything looks normal. But the moment you make a 3D imaging, you see there is a small, what we call a bleb or aneurysm, which has actually ruptured. And this wouldn't have been picked up in the previous conventional angiography, which we used to do. So this is what we now have the advantage of identifying a lesion and treating it. So this has made a huge change. And then now we have got this 3D DSA images, which you can go around and actually have a beautiful outline of what you're dealing with. And this again is so much vivid to the clinicians as well as the radiologists that on spot you can make a diagnosis of the approach, the possibilities, you need a surgery, you need a coiling. So everything can be decided based on the imaging technology that we have now, and life has become so simple. I tell you this story. This is a nurse, and tell me where. This was in United Kingdom. This nurse has been treated by the neurologist as migraine patient for 5 years, till such time that she begged to the clinician that please get one MRI done. I want to have a look at my head. And lo and behold, when the MRI was done, as you can see, there's a ball-like thing here, which is actually an aneurysm, blowout of the blood vessel in the posterior circulation in the hindbrain, And this definitely changed the total outlook of management in this particular lady. And she's lucky that this did not rupture. So with the modern technology, we now have the facilities to obliterate these, what looked to be a dangerous lesion. So this is the lesion which was there on angiography, and look, with the coiling, the whole thing has been obliterated so beautifully. So these are the advancement in technology, and now they can also use pipeline stenting and many other things, which has made life so simple for things which were really very difficult in the past. So radiologists have now also joined hand with the neurosurgeons, and they are making a very useful contribution in this field. I was talking about MRI scan, and this is how you can beautifully see a tumor in the posterior fossa, and we're talking about the posterior fossa proton beam therapy. This is the medulloblastoma which was operated, and subsequently the total tumor resection was possible. This is again another beautiful depiction of how radiology can pick up things even in a neonate. This is a 1-day-old child, and tell me where. This was in Sheffield, in United Kingdom. This child was diagnosed to have something abnormal in the brain. Despite this finding, the parents still wanted the child, and they went ahead with the pregnancy. And on the day of delivery, I was on call and I was called, and you can see there's a large tumor, which is again a medulloblastoma, which is there occupying the midline of the vermis, virtually occupying whole of the posterior fossa. So this child was definitely treated, operated in 2 stages because the blood loss was quite a bit, and then subjected to chemotherapy. So this is still possible nowadays. And this is what we can always plan and see things based on the radiology. Sorry. Now let us talk about some of the technical advances that we have. This is a picture of a drought, a dry parched land. The brain can also have drought. Look at this picture. This child, half of the brain is devoid of blood supply because this child suffers from a disease called Moya-Moya disease, where the blood vessels get gradually obliterated on their own. And there is a lot of research going on this. So when there is a parched land, you put a little bit of water, the land immediately soaks away the water and is thirsty for having some water. So this brain is also thirsty. So what we can now do, we can now do bypass surgery of the brain. We earlier talked about, we know, everybody knows that there's bypass surgery of the heart, which is done left and right actually. But now we have got bypass surgery of the brain, where you can even anastomose a 0.5 millimeter vessel, which is the superficial temporal artery, to an artery, to the branch of the middle meningeal artery in the brain. And this is what was done in this particular child. As you can see, this is the preoperative picture. So with the microscopes that are available, with the suture technology which are available, we can now see how this brain has been revascularized. So this is bypass surgery of the brain, and in situations where the brain is getting devoid of blood supply. But technology is important. Without technology, now we know that we cannot really advance in science. So let us see what are the technological advances we have achieved. And I'll just briefly go through just the main headings, of course. We talk of precision, we talk of pinpoint line, talk of getting exactly to the spot where we want to go. So this was already there. And what I'm talking of is stereotaxy. So you put on a frame, you know the X, Y, Z of a lesion, and then you can really go to the lesion, take a biopsy, or even enter into that lesion and do the surgery. So this was already there. This knowledge was there earlier. But then what happened was the technology of imaging got integrated with the present method, which is called neuro navigation. So what is neuro navigation? In simplistic word, we see that even a taxi driver nowadays uses GPS system. So this is basically a GPS system of the brain. So what we do is that we have the images of the brain, which are loaded onto the system. And then with the cameras, which you can see the 2 cameras on the top, we tell the system where the nose, where is the head, where is the eyebrows. So the whole configuration of the skull and the way it is fixed on the operating table information is given to this machine. And this machine simply orients the images in the same position where the head is positioned. And that way, then we can have the freedom to really go into any area. Now we have to understand we cannot mess around in the brain. Every millimeter of the brain is very important. So to see that we don't really stray into a wrong area, we can just get localized and have a precision to reach the exact target where we want to go. This technology has made a huge difference. And now we can really even map our approach, our incision, our opening of the skull, and without touching any vital structures or important structures and safeguarding the important areas of the brain, we can now reach the spot where we need to do the surgery and stealthily come out of the system. Another thing which has made a difference, I was just talking about it, was radiosurgery, and we have already heard about proton beam therapy. Now, radiosurgery is an example of precision, which I call as a surgical strike. You just strike the area with radiation, and this was Lars Leksell in Stockholm who developed the first gamma knife surgery machine. This precision that we have is very amazing. It's a very simple device, what it looks to be now, of course. It's a helmet which has got 201 holes. So you place the helmet and fix it to the head in such a way that these 201 beams which will travel through the hole strikes a point. It's like holding a lens on the paper. And when they at the center of the lens, the paper gets the maximum heat and it burns. So similarly, these 200 beams would travel through the brain. And as you have already on the software, we already mapped out the area where these rays are supposed to reach. They hit that area with 201 times the dose. And obviously the radiation effect is tremendous, while the surrounding brain just gets only 1/200th of the dose, which is minuscule. So this is a technology which really works for lesions, but any lesion which is less than 2.5 centimeter will be amenable to this sort of treatment. Beyond that, the errors and of course the damage and the risks become high. So this is one technology practicing gamma knife radiosurgery. But then this was a technology which was used for the skull and the brain because the structures inside like lungs, liver, and other areas of the body. So this is again, I'm showing you the picture of gamma knife radiosurgery, how the frame is fixed. We localize the lesion, we put the patient in the helmet, and then of course, after giving radiosurgery, gamma knife radiosurgery, the lesion starts shrinking. So coming to these organs which are moving like the liver, the lungs, there, of course, a new technology has come up where we call a Cyberknife. Now, what happens here is that the lesion is sighted by the cameras, and the source, as it moves with and the source move in a tandem way, so that even the source is oscillating along the oscillation of the lesion. And in that way, we can deliver the desired therapy to that particular area in the body, where of course you can't fix it with the frame. So this is called Cyberknife. We always talk of nowadays robotics, and we already know that robotics is being used in urology, in gynecology, and many other specialties. So the question might come, is neurosurgery lagging behind? Well, we are not very far behind, but yes, we still have to catch up with others. There are now robotics which are coming up where you can really very precisely, the robot can function and do certain procedures in neurosurgery like biopsy or removal of defined lesions in a better way, and you don't have to really struggle. So you can have what is called a robotic telesurgery, where you are sitting 200 miles away, and just you're sipping a cup of coffee, and with the joysticks, you're trying to remove a lesion for a patient who really cannot come to you. So this is a possibility, but I have to tell you, to be honest, it is still quite a long way to really think of this sort of lesion situation, and we might have to wait a little bit to come up with the solution to this. We all know about the term tsunami. And now we have got the tsunami warning system, the earthquake warning systems. So when there's a patient who is unconscious and there is some problem in the brain, whether there's head injury or any other lesion, can we really be aware much earlier that this patient is deteriorating circumstance in the brain? What are the warning systems that we have? One of the very commonly used warning system is the intracranial pressure monitoring system. We know that after head injury or any brain swelling, there will be rise of blood pressure. The pressure inside the brain, intracranial pressure. Now this intracranial pressure would rise slowly, and if you are not aware, it might come to a stage when the pupil will dilate, and that's too late. So now we have got very beautiful intracranial pressure monitors, which can be inserted in the brain. This is a child with head injury, and there's a real-time monitoring of the intracranial pressure in the form of waveform, as well as the values given there. And before the pressure really goes out of hand or is not amenable to any further treatment, we can really see the pressure rising, take the remedial measures by medicine or even surgery, and see that we avoid disasters before it's too late. We now talk of minimally invasive procedures. People talk of laparoscopic surgery or endoscopic surgery. So the question comes, are endoscopes also applicable in the brain? We know that the endoscope is a device which is very small. It's like a keyhole. You look through it, but through that hole, you can see the whole sky. So that's the beauty of having endoscope. And fortunately enough, neuroendoscope has come a long way now, and we have got these neuroendoscopic equipments dedicated purely to the brain. Now, the very common lesion that we remove through the nose are tumors in the base of the skull, and the commonest being the pituitary tumor, which we remove. And this is how you go through the nostrils to the nose. So without making any incision in the skull, without making any cuts in your forehead or head, you can enter into the base of the skull and remove lesions. So this is the tumor, a pituitary tumor on the left side, which has now been removed, and this is the post-operative picture. So this is now a routine practice nowadays. So you can see in this diagram how with the endoscope, we can move right lesions from the frontal area, from the front of the forehead region to the back base of the skull there. So it's a huge sort of advancement in the technology where we can remove this. Specifically in countries like United Kingdom, driving is banned for 6 months. You can't drive. You're not allowed to drive after a craniotomy for 6 months. Such sort of restriction. So this is definitely very helpful. And without cosmetically, of course, it is very much appealing to the patient. Not only the brain, the spine surgery has revolutionized. And as you can see here, I'm giving a very classic example. This is a young man had a mobile accident, and you can see this picture. It is as if the whole upper part of the spine has been totally dislodged and disjuncted from the remaining part of the spine. But mind you, this patient is neurologically completely intact. Now you can see the way the bones have been shattered here. And just with the technology now, we can do a fixation. This is fixation from behind first, where you keep the pieces together and then go through the mount and fix the front part. So this man is back to normal with the help of the modern technology of the fixation that we have. Similarly, we have other technological methods where even with a small incision, we can fix any instability in this upcoming and evolving technology every day that we see. And this is a man with a metastasis where the bones have been destroyed because of cancer, and we have fixed the spine 360 degrees from his normal function and living a quality life. What about certain restorative procedures to restore any disability or debility in the body? We'll talk about that. We have heard of the leaning tower of Pisa and how it balances itself. But mind you, if you really calculate the physics here, the amount of stress which the ground level is there has to be understood. Similar situation occurs in the elderly people. We are very common to see patients suffering from osteoporosis. So if there's osteoporotic collapse, the spine, instead of remaining straight, would then bend, so becomes a leaning tower of Pisa. That puts a huge amount of stress on the posterior elements of the spine. And this would definitely progress if something is not done. So this is an old man, he's a Parkinson patient who came on a wheelchair. This is the collapse that he had. Simple thing, you just inject some bone cement, a biocompatible cement which goes and becomes hard there and stops this from further deteriorating. And this can be done just with a C-arm on the operating table without any general anesthesia. And within 2 weeks, this patient came walking to me. So this is now a very commonly practiced procedure for osteoporotic collapse. And you can again use balloons to make space and fill up these osteoporotic areas with cement. So that is how the technology has also advanced. The debility because of various other
Dr. Pathak, if we could sort of finish it up quickly.
Factors in the body, you can, yeah. So this is you know, in epilepsy, there is a total disaster in the brain, and intractable epilepsy, you can produce the cessation of the seizures by stimulating the vagal nerve, and that's one of the technology which is there. Similarly, in spasticity, you can use the catheter to deliver the drugs in the spine and reduce the spasticity. So just like a container through which the drug is released slowly in a regular pace, the patient can improve the quality of life. That this is the picture how the pump is there, which is delivering the drug in the spine. Pain management, and again done. Similarly, you put a catheter in an electrode in the spine, which is connected to a stimulator, just like the pacemaker of the heart, and this stimulates the spine and gives relief to the brain. So for pain management also, this is all functional neurosurgery I'm talking about. And this is how the electrode is placed, and you can have relief of the chronic pain which is debilitating to the patient. You know, migraine is a huge problem, and it is very common in the younger generation nowadays because of use of various technologies, mobile and computers and things like that. And there's interactive migraine. You can just make an incision at the back of the skull, put some electrodes, and then stimulate the occipital nerve, and the migraine gets controlled. So all these technologies are very much there and available for us. Last but not the least, I would talk of deep brain stimulation. But Parkinson patients, those who have tremors and have difficulty in walking, by putting the electrodes deep inside the brain, and then at a regular pulse, you deliver the stimulation to the subthalamic areas, and the patients are better. So all these things have made an excellence in the field of neurosurgery, and what it used to be some 30 years ago has rapidly changed. So I just want to point out and say that excellence is not a destination, but a never-ending journey. And I'm sure in another 10 or 20 years, neurosurgery will rise to much, much higher levels with much modern methods of treating patients. Thank you very much for your patient hearing.
Thank you, Professor Pathak. So that was really very elaborate discussion of your topic, primarily focused towards technology, how it sort of changed the treatment plan, therapy, as well as the diagnostic accuracy of many neurosurgical things. And it's very nicely covered from the primitivity to modernity. I'm sure that it will continue to become much more advanced, and patients of neurosurgical problems can certainly do very well. Any quick comment by anybody in the panel? Amit?
Yeah, so the currently also the artificial intelligence coming in big way along with the machine learning. where the robotics are really getting enhanced. And in fact, the setting of the goal, if it can be done by the surgeon or whoever is the expert, then accordingly the suggestion optimization of the procedure can be done in the AI and machine learning interface. So that means these technologies are going to improve very quickly, and in future the robotics will be also redefined itself with AI, because it's like it will learn itself
In fact,
with more experience. Yeah.
Agree. Yeah, Srinivas, you got any comment? Srinivas?
I have a question
Sure. Go ahead.
Yes.
to Dr. Pathak. Very nice presentation, sir. Very inspiring. But the thing is, I want to ask, the robotics has, I mean, you've shown the endoscopy, the microscopy. The robotics is come in a big way in several other sites for gynecological, genitourinary cancers and gastrointestinal cancers, primarily mainly visceral. So do you see the similar impact of robotics in neurosurgery in future?
We do envisage that, but at this present moment, we have got only 2 or 3 centers, 3 centers which have got robots. They're basically used for limited purpose, like taking a precision biopsy, where you just tell the robot where to go, that goes and takes a biopsy, or you just make some incisions using a robot where, you know, the human hand can have tremors, but these robots, you know, they are tremor free, and so they can do the work much better. But we are aware of the fact that now robotics are used for removing clots in the brain. These are all in the experimental phase. So yes, we are still behind what in the field of robotics, so far as the other specialties are concerned, but work is on. The problem is in the brain, the structures are so delicate, the refinement of the technology will take a little bit of more time. So that is awaited. But already, as I said, in Hyderabad, in All India Institute, Delhi, and I think one more place I'm forgetting, that we have got the robots which are there. But these are still, I would say, in 10 years down the line, people will say these are primitive robots.
Dr. Pathak and Dr. Srinivas, just a quick comment from both of you. So Dr. Pathak actually spoke about the gamma knife, and you spoke about proton. Are they sort of complementary to each other, or they're independent? Sort of, if you could educate me on that.
If I may, sir, Dr.
Yes,
Pathak,
yes,
if I take the question first.
Sure.
The gamma knife still has its own huge advantages as far as the penumbra is concerned. For smaller tumors and for tumors which can be treated with a single fraction, I think gamma knife still remains an excellent option. I don't think any technology as of now, I mean, there are many additions to the gamma knife now with image guidance and other things which are coming up. And of course, the Cyberknife technology, which is very similar, except the fact that the particles, I mean, instead of X-rays, instead of gamma rays, it's X-rays. But proton therapy essentially is for slightly larger tumors. When you have larger tumors, the benefit of protons is even larger. And specifically, I would say the only indications which are currently being used for gamma knife, for example, in a younger patients, I would use proton therapy for those patients such as pediatric AVMs. There have been large series for pediatric AVMs on protons, and from Harvard, from almost from 90s, they have treated so many patients. So except these, I don't think there are any overlapping indications as far as gamma knife and protons are concerned.
Right. Thank you. Professor Pathak, quickly.
No, gamma knife definitely has got advantages. There are certain benign tumors which are very regularly being treated with gamma knife. One of the common things is acoustic neuroma. So obviously, the cost-wise, the treatment of acoustic neuroma, AVMs, and benign pathologies like this would be much cost-effective using gamma knife, unless they're too big in their size. The only limitation is the size. But now they are having various other methods of treating larger lesions. At the same time, it's a single sort of sitting therapy. You have it shot in one go and the treatment is over. So yes, they are complementary to each other, or you want to say them, they are two different technologies which are helpful in their own way, but both are definitely viable technologies and very, very effective.
Thank you. Thank you. I think we'll close. We will.
So I have one very
Dr. Chaudhary, please go ahead.
Simple question, and I do not know whether Dr. Pathak, you remember me at PGI as a trainee, but I have seen you there. Obviously, I know Amita very well and Ravinda very well. So one simple question that in respect to technology now, molecular imaging is coming to characterize the tumor or inflammations. Molecular imaging beyond PET imaging. So are there any of these applications being applied in brain tumor, brain surgery? Dr. Dinda, you can also share.
I think Amit is the right person to answer this. I don't know, Professor Pathak, you could comment on Dr. Chaudhary's question.
Yeah. Yes. Now, even in the radiological suite, now they have got the various sequences, and there are studies now which have come up. They even make the grading of the gliomas based on radiology. Work is on. There are published papers on that. So yes, and here the role of AI is going to be important, where they will pick up these things. So that's number one. On the operating table, we have got this various dyes now which are used, and these dyes, like we use fluorescent dye, which can even tell you the infiltration of the tumor, how far it has gone under the microscope. We just change the lens setting on the quality microscope that we have, and we can even have the blue dye, which tells you the infiltration of the tumor, which is not seen on the routine MRI. And this can even help us to remove the tumor in a better way and go for gross total excision, which sometimes in the past was never thought of. So yes, things are again changing at the operating table, but radiologically, the radiological advancements that we have, we can now even differentiate between what is recurrence from what is progression of the tumor, what is pseudo progression of the tumor. So all these things have changed. And as I said, I really, my hats are always off for the radiologists and the technological advances they're having every day, which is making life so simple for us, especially neurosurgeons. So yes, what you said is absolutely correct. It is possible.
Thank you.
I think with that, we'll close Dr. Pathak's session. May I now request Professor Amit Dinda, a very accomplished pathologist, now become nanoparticle specialist from All India Institute of Medical Sciences. He's going to talk to us on the nanoparticle in nanotechnology application in management of cardiovascular diseases. Dr. Amit Dinda.
Yeah, thank you very much. I really thank Robin and other organizers for giving me the opportunity to come back again in this forum. Now, let me tell you that if you look at the precision medicine and emerging technology in medicine, then the nano is one of the enabler. And in fact, the nano intervention is there in a big way coming up in all the molecular imaging as well as functional imaging system. And now other important issue is that there is a huge explosion of knowledge in the material sciences, hybrid material, new material, biomimetic material. In fact, with the synthetic biology and our advancing knowledge of molecular biology, we are so powerful, we can recreate any kind of tissue in the body by altering the material structure of the synthetic materials. So with that few word, I think I'll start. So basically, quickly, next maybe 15 minutes, I'll try to compress my. I think those of you, I'll try to make things very simple because nanotechnology has advanced quite a lot. Now we are talking about the 4th and 5th generation of nanotechnology, which are stimuli responsive, intelligent nanosystem. So some of these examples I'll give in cardiovascular disease, which are in past preclinical trial. Some of them are initial clinical trial phase. So things are moving pretty fast. In cancer, the nanotechnology applications are already in the market. I mean, a lot of oncologists are using many of these formulations, and some other areas also there. But the cardiovascular area, still there are, I think, some time will be needed to bring in these nano interventions in cardiology practice. But anyway, to sum up, I will give into the therapeutic potential is actually focusing. two areas I'll focus. One is the ischemic heart disease, and other is the thrombosis. I mean, so how the nanotechnology can help to treat these two important conditions. And then also I'll have end my talk that what is the problem, why it is taking so much of time to bring these technology to the market or used by everybody. Now, nano, basically we deal with the material which are in the size of a virus, I think, and the 100 nanometer and around that. But nowadays we say anything submicron can be nano. And the material, if you see, materials are ranging from metal, protein, the polymer, the lipid, anything we can use for making nanoparticle. And depending upon what kind of use we want to do, we can choose the material. So, for example, in your COVID vaccine, couple of COVID vaccines are using liposomal system and solid lipid nanoparticle system. In fact, so they're carrying the antigen and regulating the antigen presentation. So there are several examples of like that. And if you see, the nano is really in everywhere now, from textile industry, everywhere. I'm not going to the detail. In your energy sector, your car and transport, everywhere it's now being used. Now, basically, if you look into the next decade when we are moving towards these, the system of the nanotechnology applications with different industries are changing very fast. In fact, we will be moving towards the nanoscale industry in a nano way. Say, for example, the big labs, pathology labs, which you are running, they in future they'll be replaced by small devices with lateral flow assay, which are becoming very accurate nowadays. And in fact, they can replace the very costly energy consuming the technologies will be replaced by more simpler and small technology with the nano. Example I am giving, the nanochip for nanofabrications is being used in computation in your cell phone and many of these structures already. So if you look into the nano investment, say it's more than 3 trillion. I think it's crossed. This is a little older slide. I have not reviewed current situation. So that's a huge area of investment in nano. So nano is coming up everywhere. In India also, we are not far behind in the pharmaceutical sector, where I am part of the regulatory system development in India. When we reviewed, we realized in India, pharmaceutical giants are also investing huge amount of money for nanoformulation development, and almost $1.6 billion amount growth is expected in the next couple of years. Now, in AIMS, we have done a lot of work in the nano area. I'm not going to the detail, but we have both the diagnostic and therapeutic side, and we have done with the gene delivery system, different kind of drug delivery system. And our lab has got 14 patents, and out of which I think 4 are undergoing technology transfer. But the cardiovascular applications, though we have worked in 2 applications, but I have not progressed further. So I will not be talking much about that, but I'll be giving you an example what is the latest happening in this field. Now, the therapeutic areas of ischemic heart disease, the major issue is that how you target your biomolecule or drug to the heart, or not in the whole heart, but the area of damage. So ischemic heart disease is one of the examples where the part of this heart is infarcted and then ischemic zone develops in the surrounding the myocardium. Now, if you want to intervene very specifically, then we have to send our drug or biomolecule through the nanocarrier precisely in that area. It's a very difficult job to do. So basically, one of the suggestions is that if we can target the macrophages, and during inflammation, these macrophages will also infiltrate in the area of infarction and surrounding ischemic zone, and then it can carry your therapeutic molecule over there in the area of infarction. So in fact, that means if you can target the inflamed macrophages, then it is possible that you can reach the cardiac area which is damaged for their therapy. So we worked in macrophage targeting long back. I think initially we targeted managed receptor with gelatin nanoparticle. We have shown that they have got a very high macrophage pickup. But then this also we realized entered into liver and spleen. So next phase of work which we published last year, we picked up the folate receptor beta. Now folate receptor beta is mostly expressed by the macrophages which are in the inflammatory phase. So that means any area of inflammation, the macrophages which are recruited over there, they will be very, very attracted if I can have a folate receptor beta ligand on my nanoparticle. And with that system, we have worked in rheumatoid arthritis, and we have shown that in following intravenous injection, they really accumulate in the inflamed joint. In the rat model we have shown. So basically, but cardiovascular system we have not worked. But then another area which we have worked a lot and we are working is that the target the initial phases of atherosclerosis, targeting the macrophages over there, and the delivering the siRNA to in fact the block the oxidative LDL pathway. Thereby you can actually reverse this macrophage metabolism and also regression of this atherosclerosis. But we realize the problem is that if it goes beyond stage 2 atherosclerosis, where already some amount of plaque has been formed, then our the intervention doesn't work, because very initial stage, if we can actually target these macrophages, so then it works. So obviously, though we tried to develop a new kind of therapy, but it was not successful, so we didn't pursue this area. Now, apart from that, now let me concentrate in the ischemic heart disease. Now, what people have done, there are nanogel system which has been actually developed. These are basically nanotized hydrogel system, hyaluronic acid, alginate. They have a very sticky kind of character. And if you can infiltrate in the surrounding area of this infarction, and then you can inject through these the intravenously the pegylated the nanoparticle containing these growth factor, the infiltrated nanogel can attract them with a ligand and receptor interaction mode, and you can concentrate your growth factors in this recovering zone, and so that you can enhance this recovery of these cardiac damage. And similarly, the another thing which is now under clinical trial is developing the nano patch. These are nanofabricated patch in which you can incorporate the stem cells and some of these cardiac stem cells and the transformed stem cells are being used, and you can align them in these nano patches, and this has to be need surgical intervention where you can place them on the area of infarction near the heart, and then these stem cells they mature into cardiac muscle and incorporate in this reparative zone. So these are the large animal trial has been finished, and I think these are initiating into some of these initial trial in the human. Now next comes more complicated thing. We realize that if you look into the advancement, now the interesting thing I have noted, the majority of these very advanced cardiovascular nano intervention is done by Chinese group. I mean, in the nano area, they are also doing extremely well, but cardiovascular research and with the nano, there are several groups have picked up. Now, what these guys did, the Lin et al. Yeah, so what they did actually, so they picked up the melatonin, which is a very potent antioxidant, and then they covered with the polyacrylate covering, and on the top of that they have put the circular mitochondrial DNA, and then they put it with a ligand which can be attracted towards some of these inflammation associated molecules. And when they injected it intravenously, they showed they can accumulate in the mouse model and rat model, accumulate in the area of inflammation. And then when they enter into the area of inflammation, so they function as a stimuli responsive way to release these melatonin, and also you can deliver VEGF and other growth factor in the reparative zone with this. Now, the stem cell is a problematic thing, we realize, and still there are regulatory issues. So the people, what they have done, they have developed these microparticle, which is around 2 to 3 micron of the different kind of polymeric system, in which they have incorporated the different growth factors, and sometimes they have also the cardiac stem cells which are grown outside, and the factors liberated by the cardiac stem cells is loaded into these particle, and then they injected this particle in the area of the infarction surrounding that area. So what it does, that it releases this growth factor in this ischemic milieu, and then it stimulates the repair of this damaged area following infarction. And so these papers have shown documented. This is obviously in the animal model it is done. Now the other area which is actually the several companies are working, that different hydrogel formulations are being developed for both the nanogel technology which I have told you, and as well as is the infiltration technology in the area of the infarction, surrounding the area of infarction. And these can be loaded with different kind of nanosystem which can have a microenvironmental stimuli responsive release of different kind of growth factor as you need them for repair of this ischemic zone. And in fact, this is a large animal trial which have been shown the successful demonstration of this technology. And this technology is also now in the first phase of, I think, initial phase of clinical trial in Europe. I think in the France also there are 2 centers who are doing it. Now, after that, I think I'll give you certain examples of these thrombosis. Now, in the thrombosis, when there is a clot formation, there is a big challenge. We have to identification of the clot formation, the application of the nanotechnology is very easy now. But we have to realize that we have to know whether it's an old clot or whether it's a new clot. That also indicates its friability. And also when you try to dissolute it with some kind of force, the response or danger out of that clot lysis we can also assess. So if you look into, this is a review article in last year it came. In this review article, if you look quickly, I'll mention. So there are mechanical thrombolysis where we can use the iron oxide nanoparticle, and with magnetic force, if you could vibrate, it can incorporate into the area of the thrombus, and then after that, if you vibrate, then thrombus can lyse. Then there comes these imaging guided, the NIR imaging. So both the photoacoustic imaging we are using with a nanoparticular system, which can also dissolve these clot thrombus. I think I'll show you how it is done. Then we can load the different drugs into the particle, and we can have the fibrin associated peptide, which can actually in fact target these fibrin degradation at a particular phase in the clot. So when you put them into the vessel, and they can go in and accumulate into this clot forming area, and then after that they can release this thrombolytic drug. So there are all these things are being tried, and many of them are also has done significant good result in larger animal studies. So this is one of the example where fibrin specific peptide has been conjugated with gold nanoparticle, and then when you inject it, so it is a very, very good enhancing for the CT based diagnosis. We do MR angio and that kind of thing, but then this can have a much more easier way to pick up this clot, and then they detect it where it is and how it is formed. Now the photoacoustic imaging is another thing where you are using a laser which send its wave to heat up very mildly the thrombus. And when it hits up, it also emits the sound wave. This sound wave is picked up by another detector. So this is a photoacoustic imaging system. Now, if you use the nanoparticle in that, which gets activated when you are putting the initial laser, and it accumulates inside the clot, then it is easy to lyse them. So that is the technology is being developed, and this technology is showed very good prominence in the pig model, and I think this is ready for human trial, rabbit model and pig model, and now it is good for I think next phase is ready for clinical trial. And similarly, the ultrasonar and photoacoustic base, the disruption of the clot following targeting by the nanosystem is also a big area where this controlled dissolution of these thrombus can be achieved. Now, these will be very, very useful technology for the brain, the stroke, as well as in the cardiac, the thrombosis or atherosclerotic thrombosis. And but then the regulatory issues are major issues in this, because it's not so simple, because the embolic or thrombus associated with atherosclerosis sometimes are very friable. If we disintegrate them, they can be smaller, they can go in the periphery and block other vessels also. So I think optimizing these technologies is a big challenge, and though they are very successful in animal model, But I think regulatory point of view, I think people are looking into it in much more detail, because heart is a very, also like brain and heart, these are very, very, I think, organ of high importance. So we cannot play with it. Now, the similarly, this another thing where the perfluorohexane. So this is also we have worked with the perfluorohexane. You can load it with the nanoparticle, and the perfluorohexane is a very interesting. This is in liquid phase, but the moment you put them in the ultrasound, then it changes its phase. It becomes gas. So if liquid to gas, if you change, then it produces a cavitation pressure, and which can disrupt the system in which it is embedded. So we put it in the nanosystem and put the ligand for the targeting this clot, and after that we use the one can use the low intensity, that is low intensity focused ultrasound, that LIFU. So LIFU is very mild, so that it will not cause any damage to this clot. And also with this, you can dissolve this clot very slowly, and it is a very good technology which has got a lot of potential. Now, so I have given you quite a few examples where your idea of the managing a particular damage to the heart or thrombus, removing the thrombus, can be done in the nanotechnology intervention. And the cardiac patch and hydrogel system are in the initial phase of clinical trial. Now, the regulatory clearance is the main challenge based on quality, safety, efficacy, and performances of these interventions. So even if there are fascinating results coming up in the pig model, and even if in the initial, the couple of patients it is done, but I think there is rigorous, the regulatory issues is being looked into. So that's why it is getting little delayed for further coming into the market, these technologies. So if you look into it, now, as we have the different kind of nano-enabled technology, now I always say that they can be divided in 3 baskets. Now, some of these technologies are very safe, and also they use all the US FDA approved chemical. They have no other side effect or toxicity, so they can be easily brought into for these advanced application. And some of them are in the yellow basket, where there may or may not be. So cardiac interventions, unfortunately, majority of them are yellow basket. Only 1 or 2 are coming into the green basket. So they will be coming to practice in very shortly. But I feel that nanotechnology, as I told you, is for imaging also. I have not given much example because of the time. But for imaging also, nano-assisted imaging is becoming big way, where they are enhancing the power of MRI, the CT, as well as functional imaging, and also in vivo imaging real time using the different NIR dyes incorporated into the nanoparticle. So with this, thank you for your attention, and thank you very much.
Thank you, Amit. That was really wonderful. I think we have to just more and more I listen to you. I try to get myself educated. But at the same time, I get frustrated in the sense that why I am not one of you who can actually contribute directly to advance the medical field. I have a kind of a copy-paste personality. If you could create, I copy it and paste it on my practice. So that is probably the clinicians like myself. But you are the actual people who are contributing to advance the medical field, and we feel so proud of you. And again, once again, with your presentation, I learned, and I'm sure that over a period of time, even probably during my practice life, I would be able to see the advancement and contribution of nanoparticle technology in the cardiovascular management. Before I ask you to stop, Dr. Radiosurgery, I'm sure you got some quick question to Dr. Amit Dinda.
So, Dr. Dinda, in respect to the inflammatory component of cardiac disease, like myocarditis, I'm pretty sure this technology will.
Amyloid, for example, amyloid is coming up. The nanoparticle is being usually applied for diagnosis of amyloid, but nowadays the therapy has come up, and you'll be surprised. So-called severe aortic stenosis patients who are being taken up for Tavr and this kind of valve replacement. It has been identified that 30 to 40% of these patients, they have a concomitant amyloid disease of the heart.
Yeah, Dr. Radiosurgery, yeah, you were asking me something.
So in respect to, other aspect, the inflammatory component of the cardiac disease, such as myocarditis. I'm pretty sure this nanotechnology have role in diagnosis and as well management of these conditions.
Yeah, exactly. So basically, let me tell you, because of time also, I didn't go into that details. What is happening now? We are able to now generate the stimuli responsive and as well as microenvironmental sensing nanoparticles. Now, what it does, if you put them into the vein, inject them, they actually go into this area of the disease, and we already have the array of ligand to reach into that area. And then after that, when they start interacting and degrading, they produce the secondary metabolites, and you can measure them into the blood. And these secondary metabolites are very specific to the actually the functional state of this damage. Whether earlier used to do what I do cytokine measurement, this is too in fact non-specific, because the cytokine is reflecting throughout your whole body what is happening there. There may be an infection associated with a myocarditis. So infection somewhere else. I mean, you have a cellulitis, something else. So inflammatory markers are very difficult. If you have a bad oral hygiene, then some of them time our early inflammatory markers in the heart are overlapping with your bad, due to bad oral hygiene, they may be cannot be interpreted. So those kind of problems were there. But nowadays, with the functional nanosystem which are coming up, it is possible that you can go for the assessment of the what is happening exactly at that site, disease site. Then another interesting component is coming up, particularly cardiovascular area, is the theranostics. So we want to localize them, the disease area, and then treat them. So in the two phases, it is possible to do. While you are actually imaging them, then after that, you can put either low intensity focused ultrasound, that kind of intervention, which can actually release your bioactive molecule, if you want, into that area where you have seen the concentrated in the area of damage. So there is a lot of scope to further to make a more functional component to bring in, both in imaging and therapy.
Professor Pathak, you got any quick question? Yeah, please go ahead.
Yeah, I was just very much intrigued with your talk. I'm just a basic hardcore neurosurgeon, nothing more than that. But is there anything in the nanotechnology which can remove the atherosclerotic plaques and sort of, wipe out the atherosclerotic?
Yeah, I had a big DVT project. I showed you one slide. Actually, what we did, we were expert in macrophage targeting. So we actually characterized these the initial atherosclerotic development of atherosclerosis. The macrophage, there are accumulation in the pro-inflammatory phase, and it produces one inflammation in that localized area. So we were quite successful to target them. But then we realized, and we through siRNA, we were actually blocking the oxidative pathway of LDL pathway, which actually generates this accumulation of your fat. Now the problem came when it is early, say just a patch kind of situation, then it can reverse. But the moment it goes to little early, even plaque stage, it fails to reverse that. So in a way, that was our failure of research, and I didn't pursue. But I think we can again change our strategy and work for that. But I think you are correct. So maybe there are 2 or 3 different kind of strategy has to be formed, and to remove that the accumulated fat from that area. And we have to devise some of these particles who can go over there, accumulate over there, and you can then either lyse them or remove them. Because nowadays, the another area which is coming, becoming very important is the micro machine or nano machine, that is nanomens. So you can put them inside the body, and they can go at the place where you want, and they can remove the tissue, and then comes back. So you can bring them out. So those kind of technologies are also coming up.
I think there are some animal. I read some animal studies coming up. There's a kind of storehouse. It identifies the pathology, goes there, destroys it, comes back to the main store.
Exactly.
So you can have a nano garage, somewhere. I'll put it on my right shoulder.
Yeah, so those kind of things are there. So in the nano area, I'm working for the last almost 15 years. It's becoming a science fiction now, and you can tell me something, imagine something. We can really pick up several experts and sit with them and then fabricate a nanosystem. So it is possible theoretically. Major problem is your regulatory clearance. I mean, that you have to realize that.
I think excellent. That is with that kind of note from imaginism to realism would be the future.
To address what Dr. Pathak has raised in respect to atherosclerosis or in respect to other events. So, and Dr. Dinda, you can add on this. So, nanotechnology allows also to deliver, localized and cell-targeted or molecular targeted medications. So, like as Dr. Dinda is telling that in atherosclerosis, the early event is the migration of the monocytes and forming macrophage. So those molecular events, not only for the macrophage, even particularly at the vessels in brain or in the heart, can be performed. Broadly, that's what I think. And Dr. Dinda, you can, say a few words on that.
Yeah, you have been so precise on that. Amit, any comment on Shibu's?
No, exactly. We could do that. We could do that, and we have shown that it is doable. I told that we didn't pursue it for further therapeutic development because when it is from early stage it progressed, then it didn't work. I mean, I also explained why it didn't work. But then early stage we have shown in the rabbit model and rat model that it regresses those macrophages. In fact, very interestingly, the initial recruited macrophages, many of them, they actually went away. The further accumulation was stopped. So what Dr. Raichaudhuri is telling is absolutely correct. We could do that. And so the targeting is specific targeting at the site of the disease is a huge strength of nanotechnology. I mean, that I can tell you. So if you have got any idea where you have some block, I mean, you can collaborate with some of these the nano expert who can give you some of these enabling kind of intermediary technology by which you can perform that. So
thank you very much. I think with that, thank you, Amit, once again. It's a pleasure to listen to
next time.
We all got benefited. And may I now request Dr. Shiva Prasad Raichaudhuri from University of California, Los Angeles, Davis, to talk to us on immunology.
Thank you, Dr. Chakraborty. Thank you, Ravinda, for bringing me again in this forum. And you can see my slides.
yeah, your slides are on. Yes.
Okay, my slides are not. So the title of my talk is T-cell targeted therapies for autoimmune diseases, and I'm going to talk on the progress from the biological DMARDs, disease modifying drugs, to small molecules in the field of autoimmune diseases. And the slides are not.
You can go make the PowerPoint mode.
Yes. Okay.
Yeah.
I have nothing to disclose, and there is no conflict of interest in this presentation. So what is, autoimmunity? So autoimmunity is an immune response directed against an antigen within the body of the host. And the definition does not distinguish whether this antigen is from the outside or already existing in the body. And these diseases are heterogeneous and generally chronic in nature, and these diseases affect multiple organs. So chronic in nature, affecting multiple organs, makes the condition severe and more challenging in respect to management of diseases. And briefly, these autoimmune diseases are happening because of the either activation of the T cells and B cells, which will result, immune complex formation and cytokine formation, and those things are going to damage the tissue. So this is a scientific technology-based talk to discuss T-cell targeted therapies. And obviously, I will discuss the mechanism of actions, that why we are interested in these T-cells, and briefly we'll also touch on indications and adverse effects. So T-cell mediated inflammation in autoimmune diseases, and as you can see, the primary immune response happens in the primary lymphoid organ, such as spleen, and then there the antigen. So it is an autoimmune disease, the antigen is inducing the immune response. There the antigen gets processed and generation of these T cells or memory lymphocytes, and memory is in respect to that antigen. And then these T cells needs to migrate, needs to come out from the vessels, and then they settle in a organ, or they home in an organ, such as, you know, a skin disease called psoriasis, where the T cells are localizing in the skin. In the inflammatory disease of the bowel, they are localizing in the gut. Similarly, in various forms of arthritis, like rheumatoid arthritis, psoriatic arthritis, they are localizing in the joints. And inflammation of the spine is leading to ankylosing spondylitis. And on the right side, on the top, you can see that these cells are coming out from the vessels, and there is, you know, cellular and molecular process that the T cell has to adhere on the lining of the vessels on the top of the endothelial cells, and there is a molecular interaction we call adhesion molecules, which helps to adhere these cells in between the endothelial cells and the T cells. And then once the T cell migrate, then these T cells, you can see the T cell is there, is interacting with the antigen presenting cells, or the APC. And then the T cell activation requires a specific molecular event. And here you can see array of molecules are present on the top of on the surface of the T cell, as well on the surface of the antigen presenting cell, the APC cell. And then the key molecular interaction is the T cell receptor, TCR, with the MHC, where the antigen can get in, where the antigen is getting presented. And along with, you can see the CD28 and CD86, which are co-stimulatory molecules, and they need to interact also. So there are an array of molecules which are interacting, and which is liberating these cytokines, and which is causing the damage. So little more that for the autoimmune disease, you need the genetic predilection. So the role of genes are there. So another area of molecules are playing a role, and they need the environmental factors. So genetic factors along with the environmental factors is going to induce that immune response inflammation, that T cell inflammation, which I showed in my last slide, and that is going to give the autoimmune disease. And in the environmental factors, again, an array of molecules are coming. A simple example, those who are aware of a disease called psoriasis, where a streptococcal infection is happening, and that is inducing psoriasis because it's genetic predispositions to genes like HLA-C, HLA-CW6. So if you see here in this arrow, so this autoimmune disease has a spectrum from a preclinical condition where there is no inflammation, and then as it is progressing, mild to moderate and severe form of disease. So here, you know, a huge work is going on, and technology-based work is going on. Can we identify this degree of inflammation or quantify of this degree of inflammation? Then we'll be able to apply this technology to identify its early stage, and not only early stage, we'll be able to apply the progression and the response to the therapy. So one of the scientists in our group, Dr. Sritikunareshwari, came with the idea, which I was mentioning before, the PET imaging, positron imaging, emission tomography may be able to identify this inflammation and we'll be able to quantify at different time points. So to prove this, we injected a foreign collagen, a foreign antigen, like a chicken collagen, chicken protein to the mouse. And as you see here, with time, day 0 to day 56, this mouse is developing arthritis on its paws and the toes. They're getting swollen and red. And you can see, to prove this technology, we had to do the biopsy. Now we do not have to do the biopsy. That with progression of the disease, the inflammation, you can see the infiltrates with yellow arrow. This is called planus formation is forming. And then the PET imaging is as well increasing on the right panel. So this one of the technology which can identify inflammation, quantify inflammation at different points, and proves this theory which I was talking, that how the inflammation is happening. And just one slide in between, there's this technology now can be applied even on human. And as you can see, in different forms of arthritis, psoriasis, and arthritis in human, we can identify inflammation. So coming back to the basic principle. So basic principle, now I mentioned that the cells need to adhere. On the left side, you can see the picture and then migrate. And on the right side, you're saying how these cells are interacting and making cytokines. So the question we raised, and many other people raised, that we have shown in animal, is it happening in human? So in human, we used a kind of a unique phenomenon, which again happens in a disease, skin disease called psoriasis, and we can see it, right? We don't have to use any scope. It is on the body surface called Kebner phenomenon, that if you injure the skin in those kind of patients, they develop the skin disease, psoriasis. So what we did serial biopsy of the developing lesions in the first week, second week, third week, fourth week, as you are seeing, and then took the biopsy and stained for the T cells. And you can see these are called the CD3 positive cells. In the first week, the brown dots, these are the CD3 positive cells. They are little bit, few cells are appearing, and with time in the second week, more cells are there and they're going towards the epidermis. And in the third week, you're seeing that this brown dot, these T cells are hitting and inducing proliferation. So this is a proof of concept to show that yes, the T cells which we are talking, they do come and they follow the similar biological principles which is happening in mouse. So the next question, if that happens, then if we block these T cells, we should be able to treat these conditions. So I'm talking about the field, how it developed and what technology was used. And here, you can see on the left side, as mouse is sitting and little bits, lesion is there, that's the human psoriasis. On the top, you can see we did the shape biopsy. We took off the psoriasis from this human and put it on this immunocompromised mice. And that's another technology called SCID mouse, which will not reject. And then we developed the anti-T cell drug against the co-stimulatory molecule, the CD28, to stop the activation of the T cell. And you can see on the left side and right side, in the A, this is the pathology of psoriasis. You can see a lot of brown dots. These are the T cells, and these are pouring cytokines to make the skin thick, the epidermis, and following treatment with CD28 on the extreme right, panel B, you can see the epidermis has thinned out and T cell result. So this provides the proof of principle that targeting these T cells can cause improvement of the disease. And then subsequently, based on our study and several other studies, the first T cell targeted therapy came into the market called CTLA4 IG, or immunoglobulin. And in this picture, abatacept, the CTLA4 immunoglobulin, blocks the interaction of CD28 and CD80 the stimulator or the co-stimulator molecules of the T cells. And subsequently, this field is developing that T cell targeted therapy, abatacept, can be used successfully in various conditions, psoriatic arthritis, rheumatoid arthritis, in the juvenile idiopathic arthritis, arthritis of the children, and subsequent more trials are going on this aspect on treatment of other disease, including systemic disease, graft versus host disease, and lupus. So now coming to the T cells, which I mentioned, the T cells on the top. So they make cytokines, and here you can see with time, we have identified various kinds of T cells. We call T cell subpopulations, Th1, Th2, Th17, and most of the development has happened targeting the Th17 cells. So this is a cell and which requires a growth factor, and one of the growth factors is IL-23, marked by the red star. So this IL-23 acts on this cell, and then they make the signature cytokine IL-17. That's why its name is Th17 cells. So, this I'm talking about the initial work, technology-based work we did in early 2000. So here we have applied the flow-based technology to identify specific molecules which are coming from the T cells. So here in the panel C on the right side, you can see this IL-17, which I was talking about, the signature cytokine for the Th17 cells, which causes inflammation, are coming from a specific group of cells, CD4 memory T cells. And similarly, on the right side, we demonstrated that in the skin lesions, in the psoriasis lesions and the joint tissue is marked by A on the right side, we stained for IL-17, and we could see that IL-17 producing T cells are there. So these form the foundations. You see how the technology works, that from where the T cells are coming and are they present in this disease. And then obviously we had to dissect the molecular pathway. If this what IL-17 is doing, you can see the IL-23, it's a heterodimer composed of 2 units, P40 and P19. So these molecules, more specifically P19, is acting on the Th17 cells and making IL-17A and IL-17F. Then the question came that what it is doing, how it is making the disease. So we had to work on the skin cells. Psoriasis happens in the skin cells, and the joint cells, the synovial cells, which are in the joints, and the endothelial cells, the lining of the blood vessels, and the bone, which causes the destruction, the bone cells called the osteoclast. So what is the role of IL-17? We've identified something, a new molecule, IL-17, and then we had to test on these cells, how it is causing inflammation of the skin cells and the joint cells and the endothelial cells and the bone cells, osteoclast. And here you can see what we found. They are inducing various molecules in these individual cells and forming the thickening of the skin or psoriasis or inflammation of the joints. There we call it planus formation or the bone destruction by activating the osteoclast. So that's how, this is the basis. The technologies are used to make a targeted molecule, and here we are talking about the T cell targeted molecule, and then the drugs against the IL-17, IL-17A were made, and these are some of the drugs are mentioned here. I put some marbles in my mouth to pronounce these names: brodalumab, ixizumab, secukinumab, and these are all in the market for more than 10 years and has been used successfully. So this IL-17 is made by IL-23. So now the question raised that if IL-17 works, then if we block the IL-23, and you can see in the picture on the left side that this IL-23 cytokines affects on, again, different kinds of T cells. Here you can see Th17 cells, NKT cells, and gamma delta T cells. And what they do, they are again making the poisons which induces the autoimmune diseases. And these poisons are various growth factors and cytokines like IL-17, IL-22, TNF-alpha and GMSF. So the question came that can we block the IL-23? And already you know that I like to do the proof of concept experiments. And this again, we used a very high technology based experiments. We put IL-23 mini circles. These are the genes, IL-23 genes, and these mini circles helps not to destroy the DNA. So we injected the mini circles in animal model. Dr. Chakraborty was talking about the mouse models. So you know there is a saying, to save thousands of human, we have to kill probably millions of mouse. So that's how the one aspect of technology. And you can see in the middle part that after injecting with the IL-23 mini circle, there is development of psoriasis and inflamed skin on the mouse. And then the idea was to test the IL-23 antibody. So IL-23 antibody in mice improved, the psoriasis improved. So based on this, I will shorten this thing. We are working on various of these IL-23 molecules here to show how we are doing this work on arthritis. But anyway, based on this, these are another group of molecules now recently, very recently in last 2-3 years, has been identified and already approved for the use of autoimmune diseases, including psoriasis, psoriatic arthritis, and some of the other skin diseases called hidradenitis suppurativa. And these are, some of them are very specific. On the right side, you can see P19 specific IL-23 blocker, guselkumab, tilrakizumab, and risankizumab. And then we have the P40 and IL blocker called ustekinumab. So this is the field, T-cell targeted therapies is progressing, and we are getting effective therapies, and our aim is to get minimum side effects. So these are some of the advantages. Initially, we got the IL-17 MAPs, monoclonal antibodies. Now we are getting IL-23 monoclonal antibodies. And why? Why we need? Obviously, we need to reduce side effects. So with the IL-23 antibodies, now we are getting less candidal infection, which we get more with IL-17, and efficacy. We judge by different outcomes, like one of the outcomes called PASI 75 for psoriasis is higher with IL-23. And this longer duration these medications have. So now this IL-23 antibody, they need every 3-month injections. So 4 injections in 1 year will take care of their autoimmune disease, for example, psoriasis and psoriatic arthritis. Obviously, these drugs are causing immune suppressions, so they will have side effects. But already, we are using an array of other immune suppressors, so we know how to monitor and how to take care of the adverse effect. So this slide will be interesting. So we are blocking one cytokine. So can we block 2 cytokines? It's a very new concept in the treatment of autoimmune diseases, the concept of bispecific antibodies. So here you can see on the left side on the top figure, we are trying to block 2 cytokines, IL-17 and TNF. And one drug is already there in trial, ABT 122, and showing better efficacy compared to the existing therapies in respect to the outcomes of the skin and joint. Another bi, so bi means 2 mechanism. So again, targeting 2 different cytokines here, IL-17 and IL-17F, and this is a big success already established and approved in Europe and likely to get approved by the FDA. And these are showing high efficacy in the skin and joints. And again, you see the success of the technology advancement, that how we can first, initially was just to identify a targeted cytokine, then now we are progressing to cycle 2 cytokine. But what we have done, and next I'll be talking how we can block multiple cytokines. So what we are using, many of you know we are using this group of drugs called biologics, but what we see that its efficacy is 50 to 60%. These are very expensive drugs. And then we have to change every 3 to 4 years because there is antibody formations, and these are protein-based drugs. So their efficacy goes down. So there is a primary failure, there is a secondary failure. So what's happening here? Why they are not working after some time, or their efficacy is going down? And as I was mentioning, that can we block multiple cytokines? So this is an interesting work we have done. This is just to show that I was calling that memory T cells, CD4 positive memory T cells, and on the right side is psoriatic arthritis, PSA. On the left side, rheumatoid arthritis. Both are autoimmune diseases. And we are talking about making cytokine at a single cell level. One affected memory T cells, how many cytokines are they making? So we did that study. A single cell is making a multiple cytokines. Here you can see IL-17, IL-22, interferon gamma, both in rheumatoid arthritis and psoriatic arthritis. But as well, the technologies you see is allowing us to identify that there is a more IL-17 formation in psoriatic arthritis, whereas there is a more interferon gamma secretion in rheumatoid arthritis. So rheumatoid arthritis is having more of a Th1 response compared to Th17 response. So the technology is allowing us to do that, but also you see, it is not making only one cytokine. So with IL-17 or IL-23, we are getting efficacy, but the kinetics and dynamics is not well known. Maybe at some point they're making more IL-23 receptor, and that's why they're making well IL-17, then they're responding to IL-17. And then after some time, the kinetics are changing because different feedback, and they're making maybe more interferon gamma, and at that point, your IL-17 is not working. So that brings us to the concept, how do we block more or multiple cytokines? And here, we are giving you the JAK-STAT kinase pathway. So these cytokines, these are all important cytokines for autoimmune diseases. IL-2, which causes the growth of T cells, any kind of T cells, whether it's a Th17 or Th1. And here see the IL-12, which is interleukin-12 important for the Th1. And IL-23, I just spoke in details how it makes IL-17. They uses, all of these cytokines are using the same signaling molecules, or similar, JAK1, JAK2, JAK3, and TYK2. For example, JAK2. So if you block JAK2, we'll be blocking interferon gamma, Th1. We'll be blocking a response, IL-12, Th1. And again, IL-23, that's Th17. So multiple cytokines can be blocked by blocking the signaling proteins which are induced by these cytokines. And here, proof of concept experiment on the right side, where we demonstrated, are they really doing in human? And here you can say, yes, IL-23 is inducing JAK2. So if we block JAK2, we should be able to treat psoriatic arthritis, because already we have, or psoriasis, already we have shown that IL-23 does that. So based on this principle, now this is a new field that block the target molecules, the signaling proteins, and this is a little easier, and Dr. Dinda can comment later on. These are small organic molecules that are much easier to prepare compared to the protein molecules, which is anti-cytokine, and with time, these medications will be cheaper and widely available. And these are some of the targets: phosphodiesterase 4 inhibitor, JAK inhibitors, tyrosine kinase 2 inhibitors, and this is a transcription factor required for T cell activation, ROR gamma T. So again, to make the lecture short, you can see various molecules which I was talking. These are organic small molecules are getting prepared to block this JAK kinase. So here is 1, 5, 6, and 9. That is tofacitinib, ruxolitinib, baricitinib, and then upadacitinib are already approved, and some other molecules are also approved, and other molecules are shown are going through the drug trials. So here you see the list of the JAK-STAT inhibitors. See the number of drugs. That itself says, how hot is this field? How hot is this field? And if we see, briefly, there are two generations. We are calling the first generation and the next generation JAK-STAT inhibitors. And you see the first generations are inhibiting multiple JAKs. JAKs as such inhibit multiple cytokines, and these are inhibiting multiple JAKs. And next generations are inhibiting specific JAKs, JAK1 or JAK2. So on principle, the next generation JAK inhibitors might be used to treat more selective disorders. And as we are inhibiting a selective inhibitor, so we will expect lower dose and less adverse effects. And this is to give the snapshot. So tofacitinib approved in 2012, baricitinib approved 2018. These are, first generation inhibiting multiple JAKs. Upadacitinib, a specific JAK1 inhibitor, got approved in 2019. And see, just few months before, ruxolitinib, a cream form. These are oral medication. The cream form got approved for atopic dermatitis, which can be a very resistant and suffering skin conditions. So in addition to systemic autoimmune diseases, I was talking about rheumatoid arthritis, psoriatic arthritis, inflammatory bowel disease. These medications also can be used for autoimmune skin diseases, which I mentioned here. And this is to show the slide that I was talking about, the atopic dermatitis, which is mostly children suffer, as it can be a very serious skin condition. Already 4 JAK-STAT inhibitors got approved. So the key point is that this is a relatively new field, and small organic molecules targeted against the signaling proteins, such as apremilast, JAK-STAT inhibitors, or even for the interstitial lung disease. A new molecule is coming, interstitial lung disease, there is not much good treatment, a tyrosine kinase inhibitor. So these new group of molecules are coming, and obviously, it is important that these are new medications to look for their side effects. Discussing the adverse effect is out of scope here, but we expect there will be, immune suppression, so we have to be concerned about infection. And there are some, reports that it may induce some vein thrombosis, pulmonary embolism, but some studies, not all studies. So we are working on that, how to come out from these adverse effects. And as I mentioned, the second generation JAK inhibitors are more selective than currently approved drugs and are being studied with the expectations to have better therapeutic efficacy and better side effect profile. So this is the final slide. You see, using technology, using various of these molecular principles, we have an array of medications targeting a single molecule, like TNF inhibitor, IL-6 inhibitor, IL-17 inhibitor, IL-12 inhibitor, IL-23 inhibitor, as well. The JAK-STAT inhibitors, the tofacitinib, baricitinib, and we can target specific cells, anti-B cell therapy and anti-T cell therapy. So I believe that the sky is the limit, and many target molecules are yet to be explored. Thank you for listening, and I shall be happy to answer your questions.
Thank you, Dr. Radiosurgery. I think is a very extensive presentation of T cell, role of T cell. We know about it. We read a little bit about it, but a large part of the talk actually has gone beyond I would have said above my head, but I don't have any head. So, obviously has gone beyond above my shoulder, if at all that I have. So
you have one of the best brain, not only in India, internationally you are known.
Anyway, it's a great presentation, but a lot of basics have been addressed, and which is very important for the physician to understand. Unfortunately, most physicians, they do not like to listen to the basic thing, and that is a mistake that they do without realizing the basics. And I'm very happy to say, I'm sure Amit, she was Professor Radiosurgery was originally a clinician, but look at a clinician becomes so strong in basics, and that actually creates a kind of a jealousy within myself that why I couldn't be one of like yourself or even Dr. Radiosurgery. I'm sure Dr. Dinda will have some questions for you. Dr. Dinda.
Yeah, so Shiva Prasad, it's a fantastic presentation. So that indicates obviously we are moving pretty fast towards the molecular medicine. I mean, molecular targeted precision medicine, where we are trying to block the different key molecule to get the effect as it is needed for a particular disease. Now, my question is that the small molecule screening is a big challenge, I think. And so what is your comment about that?
Yeah, so screening is a big challenge. And then, as you mentioned, molecular technologies are there. So first we are doing at the screening level, and then we are, the RT-PCR, and then the single cell RNA technology. So those technologies are helping us to determine their efficacy. And obviously it requires a huge amount of animal experiments, mouse experiments. In our time, some of our doctors used to say that, if you want to be a doctor, you have to kill at least 1,000 people. Otherwise, you could not become a good doctor. Now we say that we have to kill, millions of mice to save thousands of people.
Yeah, good. I mean, that is what a very appropriate comment by Dr. Radiosurgery. And as you said very rightly, that this technology, as we can see today, in oncology, a lot of biologics are being used. I'm sure many of our listeners from Bengal chamber may not be able to follow this, because how the change of drug has sort of revolutionized the concept, even immunology, like rheumatoid arthritis, lupus erythematosus. These drugs, the only drug I could remember used to be steroid and some immunosuppressive drug. It has changed, and I'll be surprised. Recently, I made a diagnosis. A lady who is middle-aged lady came to me with hypertension and referred to me by a close friend of mine who happens to be a doctor. And she was having hypertension, which was not getting easily controlled. Then I thought that it must be something else. So I said it is a kidney problem probably, and asked the nephrologist to have a look. And after nephrologist saw, I suggested to the lady that probably you would require kind of a kidney biopsy. And you'd be surprised the kidney biopsy turned out to be IgA nephropathy of different varieties. And we all know today that IgA nephropathy has got a huge number of variation. When I read medicine in Harrison, today's Harrison changed. And this IgA nephropathy at this age, the treatment that this lady is receiving, immunosuppressive and initially steroid, and my antihypertensive drugs are being continued. Now people are talking of even biologics for them. So that is what exactly the clinical application of such kind of basics. Maybe your thought can be your thought would be extremely important in this connection, Dr. Radiosurgery and Dr. Dinda.
Dr. Dinda, you are a nephrologist also.
Yeah.
You want to start with IgA nephropathy?
Yeah, so IgA nephropathy, actually, the last 3 to 4 years, we are understanding totally different way, because this was a pretty unexplored disease, what should I say. So like we initially in India and this southeastern region, IgA nephropathy is quite common, but we are not able to pick them up because immunofluorescence was not done very diligently. And now we are picking up IgA nephropathy, and we are realizing there are several kind of pathogenetic mechanism involved with the IgA nephropathy with different kind of behaviors. So the biomarkers of the disease progression is also a big challenge. As we are talking, I think consequence to your lecture, I am making this comment. Here the IgA nephropathy has a very peculiarity of the intestinal microbiome immune interaction is involved in that IgA, associated with the response of the autoantibody response of the body. And so there are several interesting mechanisms which are now involved with the IgA nephropathy. And that's why it is so much of variability is over there. Now, so that's why it is a very interesting area to explore. Now, I'm coming to the conclusion. So nowadays, when we are looking at a particular disease clinically, and then when we are going for a diagnosis, now, as we know more and more things, the diagnosis is becoming more and more complex, because interventions are, that's why, very, very different. I mean, as I told you, And there are a lot of variations in kidney diseases. There is a lot of variation. Like we have got a group of, say, membranoperipheric glomerulonephritis, which is secondary to some infection. So their management will be very different. Whether it is a primary, where so unknown type, there will be more immunosuppression. You will treat them very differently. Similarly, we are now realizing there is a renal limited monoclonal gammopathy. It's hematologically nil, everything is nil, but it is only renal limited expression. So my point is that, so that's why the disease are now can be defined better, but then at the same time, the management protocol, that's why it has to be very different. I mean, that's the point. And the advances which is happening now is so rapid pace, it is very difficult to keep track.
Agreed.
I'll just give you example. Conventional drug, now biologics are coming in big way. Now we are talking about non-biologic complex drug, where nano is coming into with these two. So NBCD is a big challenge for us to get a regulatory approval. So we are developing alternative test strategy for that. But I have a feeling that every day we are progressing, and for a much more precision, personalized medicine, as Dr. Raichaudhuri has mentioned. See, if you have a very immunological exploration for a particular patient, and you exactly know which are the upregulated cytokine response which is causing that kind of disease, then it is possible to block them very specifically. I mean, your comment on that. So biologic with personalized medicine.
Dr. Raichaudhuri.
So yeah, sure. Yeah, just coming just specific to IgA, this is also, other than nephritis, are there. Am I right? So various arthritis and skin rash conditions can happen with IgA problem, including just focused skin lesion, dermatitis herpetiformis is IgA form of disease. So obviously, the concepts of targeting. So one concept will be, you have to reduce the formation of IgA, and they're obviously coming for the activated B cells. So targeting the B cells with our already existing rituximab at some point, if the patient's primary fails with conventional, steroid and like Immuran and other form of drugs, this group of drugs, and IVIGG at certain points when they're very critical, this group of medications can be considered.
Yeah, thank you very much. I think we had a wonderful meeting. A lot of really good, extremely high-level discussion, I must say. So thank you very much. Just wait for a while. Angana is waiting. Angana Raichaudhuri is a glamorous lady, big pillar of Bengal Chamber of Commerce. And all yours, Angana. Thank you for your patience. I have been watching both you and Sarbani are listening to this program. And I did not have this much patience had it been not my subject. But anyway, thank you very much, Angana. Please take it from me. And
thank you, sirs. Of course, it is our, it was a, I won't say learning experience, because as you mentioned, it's not our subject, but it was really very fascinating to listen to the experts, and it is surely a great experience that we could present this session. So thank you all for carving out time from your very, very busy schedules and joining us today. So this brings us to the conclusion of Health Tech.
Angana, I think just a kind of a quick
yes.
Since Dr. Dinda, Dr. Pathak, and of course Dr. Raichaudhuri, is it normally we give conventions some memento work? If you can keep those mementos, but that can be sent to Delhi and Chandigarh, and the other one to Dr. Raichaudhuri. Maybe when I go to US, I can carry it myself. Is it possible? Hello? Memento, normally you
yes. Sir, yes, we are sending the soft copies, but yes, we will organize to send the hard copies also. Thank you.
Kind of recognition and
yes.
Yeah, you please conclude. Angana, please conclude.
Yes, sir. Thank you. Thank you once again to all of you. So this brings us to the conclusion of Health Tech. This year's topic was saving lives. and look forward to having you again next year. We will keep you informed, our speakers and our audience and all our stakeholders.
Thank you very much. Thank you, Dr. Dindar. Thank you, Dr. Radiosurgery.
Thank you.
Thank you. Thank you.
You have a nice evening, and I'm going to have a nice day.
Good day, sir, and good night to others.
What is the time here? It is 7:15 morning.
Yeah.
Is it? So he
Yes,
got up
yes.
at 4 o'clock, I believe.
Yes, yes. But anyway, it has been great pleasure, and it is a wonderful program. We all have enjoyed. Thank you. Bye.
Thank you. Thank you very much. Thank you, Ramin.